The subcommittee will now come to order. Good morning. If statistics hold true, by the time this hearing is over, 10 Americans will have tragically and I believe needlessly died from prescription drug overdoses. Today, prescription drug abuse is a deadly, serious, and rapidly escalating problem all across our nation. We have a solemn obligation to tackle this growing epidemic head-on, and I'm going to keep beating the drums until Congress, the FDA, and the DEA come up with a comprehensive plan for action. The Chair now recognizes herself for an opening statement. And the clock is not working. That's all right for me. It won't be all right for you all, though, so don't get too comfortable. But as Americans, we rally around efforts to fight breast cancer, childhood diseases, and other serious health threats. But for far too long, there have been only hushed whispers about prescription drug abuse, now the fastest growing drug problem in America, according to the CDC. Today, as the death toll from prescription drug overdoses continues to rise sharply, it's time to move this story from the obituary page to the front page where it belongs. It's time to realize that we can't simply wish this horrific problem away, not with nearly 30,000 people a year dying from it. See no evil, hear no evil often leads to a society's unspoken evil, indifference. We can do better than that, and we must. Just about everyone knows someone who is affected by prescription drug abuse, which impacts an estimated 12.5 million Americans and is now considered a health epidemic by the CDC. According to a recent Monitoring the Future national survey, nearly 1 in 4 12th graders have abused prescription drugs. Today, two classes of medicines, painkillers and insomnia and anxiety drugs, are responsible for about 70 deaths and nearly 3,000 emergency room visits a day. These are stunning numbers, but here's what's even more alarming. The death toll from overdoses of these powerfully addictive medicines is now more than double the death toll from heroin, cocaine, and all other illegal drugs combined. As a result, for the first time ever, drug deaths outnumber traffic fatalities and have become the leading cause of accidental death in America. So what's the answer? When it comes to prescription drug abuse, where are the safety belts and the airbags that we need to deploy? First, like anyone in recovery knows, we have to admit we have a serious problem. Americans today simply are prescribed too many medicines. There's a pill for just about every ache, pain, and malady. So what's wrong with that? Well, consider this. Not long ago, the DEA conducted 3 national drug take-back days, and I applaud them for that. And at those 3 take-back days, they collected an astonishing 995,815 pounds of unused and unneeded medicines. That's 995,000 pounds, not pills, in just 3 days. Today, doctor shopping is a widespread problem, which contributes to our nation's alarming prescription drug addiction rate, increases costs to all of us through higher insurance rates, and makes it extremely difficult for the DEA to crack down on abusers. Compounding the problem is an oftentimes false sense of security. If it's approved by the FDA and prescribed by a doctor, then it must be okay. Wrong. Too many pills taken at once or combining them with other drugs and alcohol can have a serious and even deadly consequence. But the issue confronting us today is much more complex and evolved than just, what have you found lately in Grandma's medicine cabinet? The black market sale of powerful and highly addictive narcotic painkillers such as OxyContin and Vicodin is big business, prompting the DEA to attack the problem on multiple fronts, from street-level sales all the way to the top of the supply chain. Targeted first were the so-called pill mills in Florida, which were largely unregulated until last year, and they routinely dispensed painkillers like they were M&Ms from a gumball machine. There's yet another, more insidious side of the story as well. After becoming addicted to prescription painkillers, law enforcement authorities say more and more people are now switching to heroin. In San Diego County, which borders my district, drug treatment experts say the use of heroin by young adults has more than tripled since 2006. Much of this growth is due to people who have switched to heroin as a cheaper alternative to OxyContin, now going on the street for as much as $80 for an 80-milligram tablet. By contrast, OxyContin sells for about $6 a tablet in pharmacies. Personally, I will never forget the very chilling phone call I received one night from a constituent of mine who told me that his son had had a gun put to his head because he couldn't pay the street price any longer for his OxyContin. So what's the answer? I believe my legislation, the Ryan Creedon Act, H.R. 2119, and the Stop Oxy Abuse Act, H.R. 1316, are good starting points. My goal is to improve prescriber education by getting doctors, dentists, nurse practitioners, and other prescribers up to speed on the dangers of addiction and to make certain that powerful and seductive narcotic prescription drugs such as OxyContin are used to treat severe pain only, not moderate pain like a toothache or a sore knee. In far too many cases, addiction becomes a much greater health threat than the original pain itself. And in far too many cases, death is the final result of a failed rehab. So let's not continue to blame this on Grandma on her medicine chest. She knows better. In our hearts, Americans do too. And I'm happy to recognize the gentleman from North Carolina, the ranking member of our subcommittee, Mr. Butterfield, for his 5 minutes.
Thank you. Let me thank the chairman for holding today's hearing on this very important subject of prescription drug diversion. And I know that this issue is very important to you, and I admire your work on it. Prescription drug diversion is an ever-growing problem in our country. In fact, a couple of years ago, in 2010, 7 million people, 7 million over the age of 12 were considered current users of a prescription pain reliever, tranquilizer, stimulant, or sedative that was not prescribed to them. Sadly, it's become clear that as legitimate prescription drug use rises, so too does the number of people who abuse these drugs, and so too does the number of people who accidentally die from prescription drug overdose. It is unconscionable that since 1990, a little over 20 years ago, deaths resulting from an overdose of prescription drugs have risen. It's risen fivefold. Something must be done, and I agree with that. But the question is what and by whom? Some of the testimony we will hear today comes from manufacturers and distributors of prescription drugs. It seems to me that the security and safeguards these entities employ is very impressive and goes beyond what might be expected. They use layers upon layers of security. They hire third parties to audit the processes and make immediate changes if a vulnerability is identified. They track shipments with GPS precision and have built in a lot of redundancy in their security procedures. Understandably, though, the further down the supply chain a particular drug travels, the greater are the opportunities for diversion. The National Survey on Drug Use and Health reported that 76%, more than three-quarters of people who use prescription drugs non-medically, gain access to them from someone they know. I think this needs to be our focus as we go forward. To that end, we need to focus on anti-diversion efforts, and I'm pleased that the director from the White House Office of National Drug Control Policy is here today to tell us about their action plan. In a perfect world, the answer to this problem is personal responsibility. But in the real world, it's clear the federal government does have a defined role to play. We need to provide greater support for education programs for young people so they can learn at an early age the dangers of misusing prescription drugs. We need to provide greater support for rehabilitation initiatives so those who are addicted to prescription drugs have access to the help they medically need. And we need to make sure DEA has access to the resources it needs to scrutinize all the players involved in the manufacture, distribution, and dispensing of controlled substances. Most involved in this process are good and honest people. DEA needs to find the ones who are not. And so I'd like to personally, on behalf of the Democrats on this committee, thank all of you for coming today, and I look forward to your testimony. I stand ready to work with each of you, Madam Chair, and our colleagues and witnesses to curtail prescription drug abuse in the United States of America. Thank you so very much. I yield back.
Thank you, Mr. Butterfield. Chairman Upton has yielded his 5 minutes for an opening statement to me in accordance with committee rules. And as his designee, I now recognize Mr. Stearns for 2 minutes for an opening statement.
Thank you, Madam Chair. And I want to compliment you for this hearing, prescription drug diversion, very important. And I'm also very pleased to have and welcome our Attorney General, Florida's own Attorney General, Pam Bondi. He's here to testify on this important hearing. She is Florida's 37th Attorney General and was sworn in January of last year. She's a native of Florida, and she graduated from the University of Florida, which I represent, so I'm proud to have her as so-called constituent. She also graduated from Stetson Law School and was a prosecutor for almost 18 years. Among her top priorities is strengthening penalties to stop pill mills in the Sunshine State, which from our last hearing, Madam Chair, on this issue, was a prevalent problem in our state. And with her dedication and leadership against prescription drug abuse, Florida went from having 98 of the top 100 dispensing physicians for oxycodone pills to having 13 dispensing physicians residing in Florida. So, frankly, her success in this effort resulted in recognition from the National Association of Drug Diversion Investigators, the Florida Police Chiefs Association, and from the Florida Board of Medicine. So I want to welcome her, and I thank you, Madam Chair, for the opportunity to do so.
Thank you, and I just want to point out that there is a hearing going on in the Health Subcommittee with the Cabinet Secretary, so a lot of members are bouncing in and out. If they're able to attend, I just want to thank the members who are here.
Madam Chairman, that's where I was until I figured out I was in the wrong place. Yeah.
I'm glad you figured out. But we do have 3 panels before us today. Each of our witnesses has prepared an opening statement that will be placed into the record. Each of you will have 5 minutes to summarize that statement in your remarks. The good news is the clock is working, and there's a timer in front of you now. On our first panel, we have the Honorable Gil Kurlikowski, Director of the Office of National Drug Control Policy. Good morning, Director, and once again, thank you very much for being here. We're happy to recognize you now for 5 minutes for your statement.
Thank you, Chairman Bono Mack and Ranking Member Butterfield and distinguished members of the subcommittee. It's a great opportunity for us to update you on this important issue of prescription drug abuse in the United States. Prescription drug abuse has been a major focus of the Office of National Drug Control Policy since my confirmation. I'm particularly indebted to Chairman Bono Mack for calling me up to her office in the first week that I was in office to really begin to educate me about an issue that, frankly, 3 years ago was not on the public's radar screen, but is clearly in front of the public today. Well, I included prescription drug abuse as a signature initiative as part of the administration's National Drug Control Strategy. As been mentioned, it's been categorized as a public health epidemic by the Centers for Disease Control and Prevention. The scope of non-medical use of pharmaceuticals is striking. The CDC found in 2008 that the opioid pain relievers were involved in 14,800 deaths, and opioid pain relievers are now involved in more overdose deaths, as has been mentioned, in heroin and cocaine combined. The vast majority of abused pharmaceutical drugs originally enter into circulation through a prescription. The quantity of prescription painkillers sold to pharmacies, hospitals, and doctors' offices has quadrupled from 1999 to 2010. And when I testified last year before this subcommittee in April, the administration had just released that month its comprehensive prescription drug abuse prevention plan. And the plan focuses on 4 major pillars. The first pillar is education. Most prescription painkillers are prescribed by primary care doctors, internists, and dentists, not pain specialists. The FDA is requiring manufacturers of these opioids to develop educational materials and training for prescribers. The administration is working with Congress to amend the federal law to require mandatory education and training for prescribers. And we are also working very hard to educate the general public about the risks and the prevalence of prescription drug abuse and about the safe use and proper storage and disposal of these medications. On the second pillar, monitoring, we focused on expanding and improving state prescription drug monitoring programs. 48 states have those laws. Despite the progress, some states lack operational programs. Many states operate PDMPs that lack interoperability with other states. But I'm pleased to report the administration worked with Congress to secure legislative language to allow the Department of Veterans Affairs to share prescription drug data with these PDMPs. Our third pillar focuses on safe disposal of unused and expired medications, and through the National Prescription Drug Take-Back Days that the DEA has collected and was talked about by the chair. The administration also recognizes the significant role that pill mills and rogue prescribers play in this issue. Our surveys and research show that with chronic addiction to prescription drugs are more likely to obtain their drugs from the pill mills than the recent initiates. And final pillar of the administration's plan focuses on improving law enforcement capabilities to address diversion. Across the country, law enforcement, regulatory, and legislative actions are forcing doctors and shoppers and shoppers and others seeking these sources of prescription drugs to be apprehended. The problem, of course, was highlighted in the state of Florida, which was in 2010 the epicenter of the nation's pill mill epidemic. But I have to tell you that working with the Attorney General in the state of Florida has led to marked changes in that state, and I couldn't be more pleased that not only she but Attorney General Conway are also here. In 2011, ONDCP, our office, supported training events because we know that if you're going to do the enforcement, it can't be just at the federal level. It has to be at the state and local level also. And experts in law enforcement need that kind of training in order to investigate these complex cases. We're undertaking a data analysis project right now to examine the ways the prescription drugs are purchasing behaviors, and whether those patterns are indicative of suspicious behavior. We held a roundtable with members of the pharmacy community and law enforcement to discuss pharmacy robberies and burglaries. We called in the heads of organizations that work on the security of the manufacturers and distributors to make sure that we were knowledgeable about what they were doing to secure these very potent pharmaceuticals. In closing, just let me thank the members of Congress for their support on the ONDCP and my executive branch colleagues who know that without your efforts and without your support, we would not make a difference in this very important area. Thank you.
Thank you very much, Director. I will recognize myself now for 5 minutes for questioning, and just ask you, with everything that your office is doing together with the DEA and the FDA, why are we losing this battle against the prescription drug epidemic? And you have mentioned a lot of progress we have made, particularly in Florida, but prescription drug abuse has not decreased. What is the next step?
I think the fact that all of these things are coming together, that we actually are starting to see some fruition to all of the work that's been going on. For instance, in the most recent Monitoring the Future survey, 8th, 10th, and 12th graders have actually reduced their level of use of prescription drugs. But I couldn't agree with the chair more that it is an epidemic, that it is so widespread, and that people still don't get it. They don't understand that these are dangerous, they can be deadly, and they can certainly be addictive. I think that one of the greatest hopes will be in the next step forward, and that is mandatory prescriber education. Physicians must be told and must have unequivocal information about the dangers of addiction, pain management, tolerance, dependence, and they really don't get that in medical school. The second part, I know you'll hear from the Drug Enforcement Administration, is on enforcement. The laws have to be enforced and people have to be prosecuted.
I appreciate that, and especially your viewpoint on prescriber education. But a problem for me, too, as we examine this problem, is there are clearly gaps in the data, and we don't really know the extent of the problem. What are the gaps and how can they be filled?
Well, quite often we rely, for instance, on fatality data to come from the individual states, and we know that depending on the particular state, whether it's a medical examiner system or others, those states can often be delayed. We also know that at times, whether it's from fatalities from driving accidents or others, that the level of examinations to determine what the cause and whether or not that person had the drugs in their system is not always as thorough as it can and should be. There are data gaps, but I'll be happy at another time to tell you about this new initiative to take some of the data and really identify and drill down into it.
I'd be happy to work with you on that. I think they're critical even for policy makers. We need that data critically. The DEA is going to testify that there are 1.4 million DEA registrants. That seems awfully high. You think that 1.4 million registrants is about right for America, or is that kind of a crazy number.
Chairman, I actually wouldn't know what the right number would be, but I think when you look at nurse practitioners, physicians, and all of the other people that hold those DEA registration licenses across the country and in the healthcare field, that the number doesn't seem completely out of line to me. I think more importantly, it's how they're policed.
Thank you. And lastly, should we be thinking about creating new classification schedules under the Controlled Substances Act with stricter regimes for the drugs that are clearly the biggest problems?
I know that issue has come up before to put those into the higher schedule. I think the more important part is to try and keep them out of the hands of the abusers, but not at the same time make it so restrictive that the issues that led us to where we are today 15 years ago, which was the clear indication that pain was not being adequately treated in the United States. I think the pendulum was too far over there. Clearly today the pendulum is too far over here when it comes to the availability of these. I'm not sure scheduling would be the right answer, but we have to bring this back to some equilibrium.
Are you working with the physicians who are saying that pain shouldn't always be treated solely with opioids and that there have to be other ways of treating pain, that this is creating an epidemic that is hurting more people than it is saving?
I have. I've heard from a number of physicians that want to be much more flexible in understanding and treating pain rather than writing prescriptions for 30, 60, or 90 days worth of very powerful painkillers. They also want to make sure that there are systems in place where they can be adequately reimbursed for treatments other than what right now seems to be a very simple and quick method, but not always particularly effective in treating pain by writing a script.
Okay, lastly, I'm going to just 22 more seconds that I do have. Something Attorney General Bondi cares deeply about are the opiate babies. Can you speak briefly to what you've learned about opiate babies?
I can. I can tell you that in the past, and having visited one of the centers for newborns in Seattle, the issue always centered around newborns and the addiction through heroin. Today, when I met and saw all of those infants and actually held one of those infants, the issue was all about prescription drugs, and there was very little discussion about mothers using heroin. And so we're building some tremendous health care costs as a result of not treating this adequately.
Thank you very much, Director. I'm happy to recognize Mr. Butterfield for 5 minutes.
Thank you. Again, thank you very much for coming forward today with your testimony. We have heard your testimony, and we appreciate so much what you do. I have a question that I would like to ask, and I may even ask it of the other panels as well. But I believe it's very critical and it's central to the problem that we are dealing with. Efforts in one state may yield declines in the number of pills dispensed or hospitalizations or deaths, any of which are very commendable achievements within that state's border. But how can we be sure that addicted individuals simply don't go to another state?
I think the key would be, in the example, would be the fact that Florida had become such as has been talked about so publicly, an epicenter for not only the use of these very powerful, misuse and abuse of these very powerful prescription drugs for people within the state of Florida, but for people traveling all the way through Appalachia and actually New York, Connecticut, and other places. The regulation of medicine is done at the state level. It is not done at the federal level, and we have to provide the training, the technical assistance, the startup money for the computer systems, and the assistance to law enforcement, particularly state and local law enforcement, to understand how to investigate these complex cases. I would tell you that greater use of the PDMPs is necessary. Not as many physicians or people in the healthcare industry utilize them as should, and that they need to be real-time and that they need to be interoperable across states. When those things come together, and I think we're seeing some of this in a number of states that are sharing the information, I think that way we can stop that balloon effect that you were talking about, Congressman.
Well, we've been looking at the data in our office, and the data seems to suggest that the total number of illicit drug users was constant for 2 years. even though we have seen great strides in states like Kentucky and Florida and even Ohio. Are we on the right path with this?
I think we are on the right path with what I believe is a very balanced way and a very comprehensive way of looking at this. I think that if I go back and look at where we were, and believe me, I'm the first one to tell you that a lot more has to be done, particularly in redoubling our efforts in some of these areas. But I look at where we were 3 years ago. As a chief of police of a city of almost 700,000 people, I was really unaware of this prescription drug problem. And I think that my colleagues who are sworn to protect people in their city and learn about what are the dangers, when you don't realize it, when we didn't realize it, and prosecutors and judges and many others did not realize it, we weren't paying attention to it. Because after all, it's a prescription, it's coming out of a medicine cabinet. It was a huge mistake. This is on the front page of every major newspaper on a regular basis. It's on television. We're moving in the right direction.
Let me talk about tribal communities for a minute, and only have a minute 50 left. As the National Drug Control Strategy points out, tribal communities have been particularly hard hit by unemployment, and combined with problems accessing health care, education, and other services, tribal communities can be disproportionately vulnerable to prescription drug abuse. A 2009 study by the Substance Abuse and Mental Health Administration found that American Indians are more than twice as likely as whites to abuse prescription drugs. What is the administration doing to help tribal communities address these unique challenges?
We started looking at that almost immediately, and a couple things that have been done. First, Assistant Secretary Echo Hawk from the Department of Interior has been a great partner, along with the Indian Health Service and along with the Bureau of Indian Affairs. We made trips to a number of the tribal lands, for example, the Tohono O'odham Nation in Arizona. And the issues around dietary issues, alcohol issues, and illegal drugs was significant, but the growing problem that was pointed out to us is exactly as you said, and that is around the prescription drug issues.
But are you working with to set up databases?
Education, so the education and prevention, and working through the Indian Health Service and the treatment service. And let me just mention on the enforcement side, for the first time, one of our high-intensity drug trafficking groups, HIDA, in Portland, includes a member of a tribal chief to help direct those needed enforcement resources back onto tribal lands.
And that includes databases and other resources?
I don't know about the database in particular. I would think that the health service would probably be more knowledgeable about that.
All right. Thank you. You've been very kind.
Thank you.
Thank you, Mr. Butterfield. The chair recognizes Mr. Stearns for 5 minutes.
Thank you, Madam Chair. Is it true that prescription drug overdose deaths now surpass our car-related fatalities?
It's true that all overdose deaths are now the leading cause from drugs. Misuse and abuse, not accidental, are the #1 cause of accidental death in this country, ahead of gunshot wounds and ahead of car crash deaths, driven by prescription drugs.
That's a startling fact, don't you think?
Yes.
Do you think, based upon that, that we should have a radical change in our approach?
I think that we haven't gotten anywhere near the attention or near the traction to something that is killing more people in this country than
And if I went back 10 or 20 years ago, I wouldn't find this statistics like it is today.
Not at all.
And why do you think that is true?
One, I think that the driver of the prescription drugs is, has been mentioned a little bit, people don't see them as addictive, they don't see them as dangerous, and they don't see them as deadly, because they're, after all, a prescription.
I think in your opening statement, you were talking about opiates were sold in 2010 to medicate every American adult 6 times a day for a month. That was in your statement.
Yes.
Doesn't that put a lie to the claim that we're just getting better at pain management?
When I've spoken with the physicians who looked at and were instrumental in the early days of undertreating and the recognition of undertreating pain, I think that was a clear recognition. And as I mentioned a minute ago, I think that the pendulum was there, and that in very good faith ways they worked very hard to make sure that people actually were adequately treated for pain. Two things were missing. One is the amount of education that a physician would need to clearly understand and recognize some of the dangers of these. The other is that, as many people have mentioned, we've become kind of an over-medicated society.
How would we educate Americans to not be an overly medicated society?
It's a pretty tough issue. It's kind of like dealing with the obesity issue.
You think
and how to
it's
get
something to
people
do with our
better.
culture today?
I think that the more important part is to educate the physicians around this, as physicians are so much more knowledgeable about dietary issues and the causes. I don't see the same level of knowledge among them and among healthcare practitioners when it comes to the addictive properties of these drugs.
Couldn't you, from your department, make it more difficult for the doctors to provide prescription drugs in the areas that are causing the overdose? Is there something that you could do?
We are a kind of a small policy shop that
You
we
couldn't
bring
make any
all of
recommendations?
these folks together. I think the key will be education and then making sure that they follow the rules. And I think that we're well on the way to hopefully getting that done.
You mentioned in your opening statement the actual cost to society estimated at $56 billion in 2007 and maybe likely higher today. Do you have any idea what the cost in terms of devastating effects on families and communities? If it was $56 million in 2007, what do you think it is today?
Well, and I think that the most recent study on the costs to the United States taxpayer on drug abuse was around $190 billion.
$190 billion?
And that includes all types of heroin, cocaine, marijuana issues, et cetera. But I think that you couldn't be more correct in putting forward the fact that it's not only a huge cost in our healthcare system, it's a huge personal cost and a huge personal tragedy. The child that doesn't graduate from high school, the employer that wants to start a new business and can't find people that are drug-free so that they will have less accidents and be more productive. All of these things play a huge part, and so the dollar cost is one thing. The tragedy to this country is another important part.
Lots of times, all of us talk about the legal war on drugs, but I think we have to consider a war on prescription drugs. And so I guess the question is, where does the current prescription drug war rank compared to our war on illegal drugs?
I think my colleagues, particularly in the Drug Enforcement Administration, when they set their goals and they move forward each year in recognizing what the drug threat is, several years ago they recognized this issue much more quickly and actually changed their direction and focus. I think you'll hear about the number of what are called tactical diversion squads, the number of investigations, the number of local law enforcement and prosecutors that have been trained in how to investigate these complex cases, because these are actually legal drugs that are manufactured and often through prescriptions or pill mills. So those are important steps forward.
Are we winning or losing?
We're moving ahead. I'm encouraged by a couple things. One, the number of dispensed opioid prescriptions has flattened. And if you looked at the charts in a number of years, it looked like the space shuttle taking off. The amount of opioids manufactured has flattened, and the fact that in this most recent monitoring, the future 8th, 10th, and 12th graders actually decreased in their use of one of the very powerful painkillers, Vicodin. I think we're moving there, but as the chair and others know so well, it's not enough and it's not fast enough.
Thank you very much, Mr. Stearns, and I'm pleased to recognize Mr. McKinley for 5 minutes for his questions.
Thank you, Madam Chairman. Briefly, I think you and I had a little conversation beforehand that we began, and we were concerned about privacy. I still would. I'd like you to expand a little bit about that. What, to me, from an engineering for a small business perspective, I'm a little concerned about very concerned about the privacy. But I know, and I think you would recognize that if there were a national registry of all the prescription drug use in America, the pharmacies could be held responsible to check that registry to find out that they just got OxyContin just one day earlier for 3 months' supply, and they would be able to say no. Isn't there something, some form? I know we don't want to have that because, as we've had other hearings here, of someone being able to hack into that information,
Right.
there are penalties that are related to that. But we all know if we had a list, if someone had a list, we could go to hold those people responsible more so than the distributors that are doing the best they can to curtail that. Tell me a little bit about what efforts we can do on security, privatizing those names so that individuals can't be identified, but yet a pharmacy would be able to know that they have now, this is their third prescription for the same medicine in the last 2 weeks. Isn't there something you're doing on that?
Look, I think
I saw this other, and I just think that's just great. Education. It works so well with teenage pregnancies and everything else, hasn't it? Sanctions against governments that they continue to do. So I really want something with more substance to it that is going to solve the problem.
Sure. I think the answer is the prescription drug monitoring plans that are done by the state. Since the federal government doesn't regulate the practice of medicine and the state does, having the PDMP, that electronic database that would be used by all physicians and healthcare professionals, that would be real time, and that in states, particularly neighboring states, that information could be shared across the states. When it's led and directed, and the startup money comes from the federal government, but led and directed by the state government, they can put in the protections about patient confidentiality and privacy. I think in the best of all worlds, that national database would be a wonderful thing. I think it would be difficult to implement because of the protections that would be needed to prevent, exactly as you said, hacking. And I think that part of that national database would be the fact that it would be 5 or 6 or 7 years in the making, when right now we have all but 2 states that have PDMPs. And as they become more well-used and more robust, will actually make a difference with their use.
So are you suggesting, and I think I understand some of it would not work with mail orders because they're ordered someplace else other than just in the state. But tell me again, do you think that if pharmacists knew by looking at a computer screen that person would he or she still fill that prescription if he knew it was being violated?
When I speak with all of the different groups and the individual pharmacists, and you look at their ethical standards and their patient safety practices, and the number of pharmacists that have picked up the phone and either called the physician saying something isn't right, or the ones that have told that patient, you know what, I'm not going to fill that because I have that information, I'm pretty heartened by where the pharmacists are. But I think going upstream a little bit, that doctor that realizes that patient that has come into his or her office has been to 2 or 3 other physicians, or that patient that walks in on Friday evening to an emergency department and says, gee, I'm traveling, or I've lost my prescription, or I need something like that. When that frontline upstream person can take a look at that system and say, well, this is the 3rd hospital you've been to this weekend, or you're seeing 2 other doctors with a similar complaint, I'm not going to be dealing with this. I think that's a help also.
So what do we do with that individual when they come in? Are they held?
They're not held because I think that unless they actually get unless there's a law violation, they're not going to be charged or they're not going to be held. But I think the other important part of this education piece is that they need to get into the treatment. I've met so many people now across this country in these travels that have become addicted to prescription drugs, have received proper quality treatment, and they're back. I mean, they're back taking care of their families, they're back paying taxes, they're back working, and I think that this is the entry point to get them the help that they're needed, because we're talking about a disease, we're talking about addiction.
Thank you. I guess we run out of time. Thank you very much.
Thank you, Congressman.
Thank you, Mr. Harper. You're recognized for 5 minutes.
Thank you, Madam Chair. Director Kurlikowski, thank you for your time here and all that you're trying to do in a very serious situation. You know, with regard to the PDMPs, what do you think the biggest barrier is in the implementation of a drug monitoring program for states whose programs have yet to go online?
One of the barriers is the fact that it needs to be real time, and it needs to be ease of use. Physicians have about, as I've been told, about 16 minutes with a new patient to assess everything. These are busy practices and busy offices, and they need to be given a tool that is easy, that is accessible in order to use it. And of course, once they do and they become schooled in it and rely on it, the physicians that I have spoken with tell me that it's a patient safety tool.
You know, we have 48 states that have authorized programs. 40, I understand, have operational programs. Are all of these state PDMPs created equal?
No.
Okay.
They're not, but we're fortunate at Brandeis University to have a center of excellence that takes the best practices, that helps those that are, and of course the heads of each of these agencies come together several times a year for us to be able to speak with them. We want to be able to make them as robust and helpful as possible, but I would be the first to tell you that some are better than others.
Well, are there some that you would hold out as a role model for the other states or for those that have yet to go operational?
I think you'll hear from Attorney General Conway, and I think Kentucky is clearly one of those states that has addressed this not just with a very robust and smart PDMP and some pending changes that they have planned in their laws to make it an even better system. I would tell you that from what I've looked at in California, the Cures system is another one. But this Center for Excellence, they have done a very good job of putting in the hands of the people that use these, develop these systems, information that's necessary.
What are you seeing as strengths and weaknesses, but as communication between the various states with their monitoring programs? Is that a weak link? Do you feel like that their communication between those states can be improved? And if so, what would you suggest?
You asked the million-dollar question, and I think you're exactly right. Some states are easier to get along with amongst each other on this particular issue and to work together. Some states, when you look at these systems and it's not a huge amount of money, but every state is facing difficult budget times. How much of a priority is it? But when I talk to these physicians or listen to these physicians in other states, I said, look, if I'm in Eastern Kentucky, I really don't want to spend the time to check Ohio and West Virginia, and I need to get to a system that's already linked to those neighboring states.
Mm-hmm. Are the PDMPs the only option out there for states to implement the sharing of this information?
Right now, on the prescription drug abuse and misuse issue, those are the options. I think the healthcare technology in the future, e-prescribing, all of these other things will play a big role in the future and make it easier and more helpful.
Oh, we want to thank you for your work on this very important topic. And with that, I yield back, Madam Chair.
Thank you, Mr. Harper. Director Kurlikowski, thank you so much for being here today and all of your hard work. You've been generous not only today, but every day in working with me on these issues. I applaud you for raising the profile for many years, and especially coming from somebody who said he didn't know 3 years ago. You certainly know now. I don't know that we have all the answers, but at least we're finally starting to confront it, and I look forward to working with you. And thank you again very much for being here today. Is there anything you'd like to close with rather than a second round of questions, something you just need to say that you didn't get to say?
Madam Chair, one, I am indebted to the committee and the members of Congress that take this issue on. You have so many issues in front of you, and yet, as I mentioned to the President, on the drug issue, when we think about keeping our kids in school and we think about who's going to be the workforce that we're all going to depend on in the future, I think about health care costs, I think about law enforcement issues. The more that we can do on the drug prevention side, and the more that we can do to get people adequate treatment and get them back into being productive members of society, none of that could happen without the will and the support and the help of members like you all. Thank you.
Thank you very much. And with that, we're going to take a very, very brief recess just while we seat the second panel. Hopefully it's 30 seconds or so. And we ask the second panel to join the table. Already on our second panel, we have 4 very distinguished witnesses who are very deeply involved in the issues of prescription drug abuse and prescription drug diversion, which clearly go hand in hand. We are honored today to have with us the Honorable Pamela Jo Bondi, Attorney General for the state of Florida, the Honorable Jack Conway, Attorney General for the state of Kentucky. Also joining us are Aaron Haslam, Senior Assistant Attorney General for the state of Ohio, and Joseph Ranazisi, Deputy Administrator for the Drug Enforcement Administration. Thank you all again for being with us this morning. To help you keep track of time, there is a timer light on your table. When it turns yellow, you have a minute to wrap up. So again, you don't have to come to a screeching halt when it turns red, but if you can wrap up your comments, we would appreciate it. So with that, we're happy to recognize Attorney General Bondi for her 5 minutes. And please just remember to turn your microphones on, and you may begin.
Thank you, Congresswoman Bono-Mack, and thank you for championing this cause. Green, got it. Thank you, Congresswoman Bono-Mack, and thank you for championing this cause on behalf of our country. And thank you as well, Ranking Member Butterfield, for having us here today, and also to Congressman Stearns from Florida, and to all the committee members. We truly appreciate this. I'm here to tell you about what Florida's doing to try to stop prescription drug abuse. As Congressman Stearns told you, just to put it in perspective, of the top 100 oxycodone dealers in the entire country, 98 of them were in Florida. Now we have 13. And that's with legislation that's been in effect barely a year. So last year we had over 900 pain management clinics registered within our state. Today we have 580, and I guarantee you that number is going to continue to plummet. I want to outline now briefly our comprehensive legislation and what we've done in our state. As you know, we have become the Oxy Express, and that's why I worked so closely with General Conway, with General DeWine in Ohio, because what was happening, people were buying their drugs in Florida, taking them to Kentucky. I had to hug a mother in Kentucky when I was with General Conway who lost her daughter 2 years ago to prescription drugs that were bought in Florida, and that had to stop. So we passed tough new legislation in our state, and we're very proud of that legislation. It's long, long overdue, let me tell you that. The common characteristics of a pill mill in Florida were cash business, $200 to $300 cash, armed guards at the door, little to no medical equipment at all, just shelves and shelves of pills. These doctors, who we call drug dealers wearing white coats, are sitting in a back room just signing prescription pads. And it was legal, and it was killing our kids. So we had very weak regulatory oversight of the pain management clinics. We had limited oversights of the physicians who were dispensing, which was very important, and we had a non-operational prescription drug monitoring program. So with that, we've now passed some very tough legislation, and we're very proud of that. One of the most important things to me was that we banned doctors from dispensing most abused narcotics, and we made that a violation of the ban, both a third-degree felony and, how do you hurt a bad doctor? Take their license away. So with that dispensing ban, we feel that we've been very successful as well. We also have we created a standard of care for physicians prescribing controlled substances. We required these doctors to either electronically prescribe or to use counterfeit-proof prescription pads, none of which had been done in our state. We also added, as I said, enhanced criminal penalties, which were very important, and required all of these pharmacies to be re-permitted by the state of Florida. We did great things. We now have the PDMP up and running, which if you have any questions, I can discuss that with you as well. And with that, you know, we can always create tough new laws and move on to something else. But what we did in Florida with Governor Scott's help, we started a strike force, and that's joint with federal, state, and local officials all working together. You can pass these laws and move on, and it's not going to work. We are targeting these guys, and we are putting them out of business. And with that, we have 7 strike forces throughout our state, and if you have questions about the strike force, I can explain that in greater detail. But what we've done since we've had the strike force is we have truly gone in and started putting these guys out of business. We're targeting them, and we're not letting up on them. We also have an educational component of this legislation, and that involves narcotics overdose prevention education, NOPE. And this task force, these remarkable people have done an amazing job of going into our schools and educating our children about this. We've also instituted, along with DEA, state drug take-back days. I've participated personally in as many of those as I could. You would not believe the drugs that are being turned in. And it's gotten so successful that we plan on putting permanent drop boxes up at our police stations and our sheriff's offices as well. At 2 drug take-back days alone, we seized over 5 tons of prescription drugs. Unbelievable. So, and we're very pleased to announce that as of February 2012, our strike force efforts have resulted in 2,040 arrests. 34 of those are doctors. We've seized 390 weapons, almost $5 million. But there's one other problem. I've run out of time, but that's the babies being born addicted to prescription drugs. And that is our newest fight this session, and we are not going to give up on that as well. Thank you for all of your efforts. And we do know we have a long way to go, but I don't think any of us in this room are going to stop. Thank you.
Thank you very much. And General Conway, you're recognized for 5 minutes.
Well, thank you, Chairwoman Bono Mack and Representative Butterfield, for your commitment to this issue. I also want to recognize Congressman Guthrie, who's not here, but who's a fellow Kentuckian who works with our drug task forces on this very important issue. Prescription pill abuse is a reality that's touched the lives of just about every Kentucky family. It's touched my family's life in a very personal way. It's ravaged our communities, it's shattered families, and it's fueled crime. Depending on which study you believe, Kentucky's either the most third or fourth most medicated state in the entire country. And the 4 you always hear at the top of the list are Kentucky, West Virginia, Tennessee, and Oklahoma. Last year in Kentucky, we had over 1,000 people that we documented died from prescription painkiller overdoses. That's more than we lost to auto accidents. And Madam Chairwoman, we actually think that's underreported, because our estimates are that only about half the people that actually die from overdoses are autopsied by our medical examiner's offices. And when you take a look at the unnatural deaths in the Commonwealth of Kentucky, what you see over and over is not heroin or not cocaine, Not even alcohol as much as you see Xanax, oxycodone, methadone, and hydrocodone. Last year, Kentucky hospitals treated over 5,000 overdose patients. This is an epidemic we first started to see in the 1990s in eastern Kentucky. Eastern Kentucky is a region of heavy industry, of laborers, of coal mines. We have more injury-prone jobs, but it's also an area of economic depression. And we had too many doctors who overprescribed, and too many people became hooked. And because of the economic depression, people figured out they could sell their pills on the street, and a black market was born. And today, when you go through eastern Kentucky, which I do on a regular basis, you'll find that about 80% of the crime, according to law enforcement and prosecutors, is fueled by the abuse and the insidious addiction to prescription painkillers. The problem has spread across the Commonwealth. It's not just in eastern Kentucky. According to a Lexington Herald Leader study not too long ago, in 120 of our counties, which we have total, 118 were up in the number of Schedule II and III narcotics prescribed. And I'm sad to report that estimates from law enforcement and those in the healthcare community say that we have only about 10% of the treatment beds that we actually need in the Commonwealth of Kentucky. I'm sick and tired of hearing about losing an entire generation to prescription pill abuse in the Commonwealth of Kentucky, so we have started a public education program for doctors and also for school children in Kentucky. I actually travel around the Commonwealth with two mothers from Moorhead, Kentucky, who lost their daughters to prescription pill abuse. And it's really important to get people like that who look like the mothers of these kids to tell them their story, because they'll listen to an elected official for 5 minutes or so, but when the mothers talk, they really listen. And here's what's disheartening. You can look at these kids, middle schoolers, high schoolers, and say, okay, tell the truth. Just because I'm the Attorney General, tell the truth. How many of you have used a prescription pill, or your best friends used it for an off-label purpose? I'm sad to report 70 or 80% of the hands will go up. I ask them how many think that prescription pills are easy to get. 70 or 80% of the hands will stay up. Then I'll ask them how many of their parents lock up their medicine cabinets. All the hands will go down. I realize it's not a problem that starts with grandma, but in some instances, particularly in Kentucky, it's an addiction that's starting in our homes. I've tried to do all I can. I've created the state's first prescription pill task force. That's my drug investigators working with local law enforcement. We're trying to collaborate and share resources in a time of dwindling law enforcement resources. We participated in Operation Flamingo Road, where we partnered with the DEA and the Kentucky State Police to round up 500 individuals who were vanning pills up from Florida in 2009. At that point, we thought about 60% of our pills in our streets were coming from Florida. Pam Bondi told me a story one time that they executed a search warrant on a pain management clinic in Broward County, Florida, and they seized 1,700 patient records. Of those 1,700 individuals they seized, the records, 1,100 of them are from the Commonwealth of Kentucky. That's what we in law enforcement call a clue. We had people by the van load going to Kentucky to bring pills back. And that's why I'm not only happy to have a friendship with Pam, or General Bondi, I should say, I'm grateful that she came along at this time. She's done a tremendous job of taking on these pill pushers in her state. As she said, Florida was home to 97 or 98 of the top 100 prescribers of oxycodone. Now they're down to 13. This issue knows no party, and it's an American tragedy. We're doing all we can. We have new legislation in the Commonwealth of Kentucky to re-regulate our pill mills. We have entrepreneurs getting in the pill mill business. We need to stop them. We have the issue of the mail-order pharmacies shipping 90-day supplies of Schedule II and III narcotics. I understand the issue of efficiency in our healthcare system, but that needs to be 30 days. And we need to make certain that we get doctors using these systems. Yes, we have Casper, our PDMP, it's a good system, but only about 25% of our doctors are using it. And on top of that, those of us in law enforcement can't see the data to do the investigations that we need to do, and I'd be happy to talk with you a little bit more about that. I've heard the questioning here today, and I'm out of time, so I'm going to wrap up. But if you want to know what you can do to help us get all 50 states up with PDMPs and with systems that talk to one another. We can do our jobs if we can get those systems up and running and if we can get the doctors to use them. Thank you very much for the opportunity to appear.
Thank you very much, General Conway. Mr. Haslam, you're recognized for 5 minutes.
Thank you, Chairman Bono Mack, Ranking Member Butterfield, and distinguished members of this committee. I thank you on behalf of Ohio Attorney General Mike DeWine and all of Ohio for the opportunity to address you today. As the Chief Assistant Prosecutor and later the elective prosecutor in Adams County, Ohio, I had a front row seat for the devastation that this scourge can cause on a community. In February 2011, Ohio Attorney General Mike DeWine recruited me to lead his prescription drug task force. Attorney General DeWine has been committed to using every resource Ohio has to fight this scourge. In Ohio, we have taken a nationwide stance in fighting back through changes in legislation, proactive law enforcement actions, partnering with prescribers and dispensers, and being proactive with awareness, education, and treatment. Through this effort, Ohio has raised public awareness, increased public education, and improved Ohio's investigations and prosecutions in both criminal and regulatory cases. However, to make a real difference, we must limit the availability of prescription drugs to those individuals in actual need and in the proper quantities. In Ohio, unintentional fatal and non-fatal drug poisonings cost Ohioans $3.6 billion annually. Between the years of 1999 and 2007, Ohio's rate of opioid distribution increased 325%. During that same time period, Ohio's unintentional drug overdose death rate increased 305%. If you will look to my left, you can see this remarkable correlation on the graph located closest to the back of the room. In 1997, Ohio averaged 7 doses of opioids per capita. In 2010, our average dose of opioid per capita increased to 67. In less than 15 years, Ohio watched that average dose of opioids per capita increase almost 900%. The chart to my left, the closest to the front of the room, will illustrate that the death rates during the current prescription drug scourge is much higher in Ohio than the death rates in Ohio during the heroin epidemic in the 70s and the crack cocaine epidemic in the 1990s. Ohio's leaders recognize the seriousness of Ohio's prescription drug problem. On February 8, 2011, Representatives Terry Johnson and Dave Burke, a physician and a pharmacist, introduced what is known as House Bill 93 in Ohio. The bill passed through the House and the Senate unanimously. With the support of the Attorney General, Governor John Kasich signed the bill into effect on May 20, 2011, and it became law. Much like Florida, our pain clinics, our pill mills, were not regulated. House Bill 93 for the first time regulated pain clinics in Ohio. It required physician ownership of pain clinics. It required prescribers to review our PMDP, our Prescription Drug Monitoring Program, which is known as ORS in Ohio. And they had to do that when they were treating chronic pain patients. Attorney General DeWine has worked tirelessly to create a multidisciplinary approach to the investigation and prosecution of prescription drug cases. Attorney General DeWine has worked with law enforcement at the local, state, and federal levels in Ohio to investigate prescription drug cases. We are currently working with county prosecutors and federal prosecutors all across Ohio to prosecute these cases. He is proud to be a part of this statewide team in an effort to protect Ohio's families. Our next step, the Attorney General believes, is to build a bridge with state and federal officials across the nation. To have a true impact, we must collaborate on a multi-state approach to combat this scourge. Ohio and the nation must be proactive, working with all the stakeholders to tackle this epidemic. When this happens, you will see success. For example, in Scioto County, one of Ohio's hardest hit counties, also a border county to Kentucky, the last pill mill was closed this past December. Scioto County has a population of approximately 78,000 residents. At one time, it housed 12 pill mills prior to Ohio's efforts. Today, it houses 0 pill mills. Just last week, Scioto County learned that accidental overdoses decreased 17% and drug-related deaths decreased 42% in 2011. This was the first decrease Scioto County had seen in the past decade in these numbers. It had been a steady increase prior to 2011. I will end with a quote from Reverend Martin Luther King Jr., who said, "We may have all come on different ships, but we're in the same boat now. Each of us may have arrived at the prescription drug scourge on a different ship, but today we are all in the same boat, and more importantly, people will die if we continue to ignore the scourge." Thank you.
Thank you very much. Mr. Ranazisi, you're recognized for 5 minutes.
Thank you. Chairman Bono Mack, Ranking Member Butterfield, distinguished members, on behalf of Administrator Michelle Linhart and the men and women of the Drug Enforcement Administration, I'd like to thank you for the opportunity to appear today to discuss prescription drug diversion and the critical role the DEA plays in securing the integrity of the controlled substance supply chain and delivery system. Before I get going, I'd just like to thank the chairman of this committee for their leadership on this problem. And I also want to thank you for promoting the National Take Back program. If I may throw in a plug, we'll be doing it again April 28th, Saturday. State, federal, local agencies with community groups working together to collect those drugs, and I want to thank you again for that. Also, I'd like to thank the leadership of Director Kurlikowski, who's gone out of his way to ensure that we get all of the resources that we need to do our job. The abuse of pharmaceuticals continues to be a significant problem in the United States, and it's based on pharmaceutical diversion from the supply chain and the medication delivery system. And we believe that's the major reason. There's just holes in the system. Over the last few years, individuals and organizations have created schemes within the healthcare delivery system that appear legitimate but are nothing more than illegal operations to facilitate the illegal distribution of pharmaceuticals. Pharmaceutical diversion facilitated by these operations can be prevented if DEA registrants would just fulfill their obligations under the Controlled Substances Act. The Act was designed so that each DEA registrant is a link in the closed system of distribution. Each registrant, manufacturers, wholesalers, distributors, practitioners, and pharmacies have a critical role to play in keeping the distribution chain closed. Two major schemes have emerged to divert millions of dosages of powerful addictive drugs. The first one, a few years back, was the Internet Pharmacy Scheme. You could go online and you could purchase pretty much any Schedule 3, 4, or 5 controlled substance you'd like. Hydrocodone was the drug of choice, and it came out of the distribution chain, and really no one fulfilled their obligations to the chain. You had distributors that weren't doing due diligence on pharmacies that were ordering huge amounts of hydrocodone. The pharmacists weren't checking those prescriptions to ensure they were valid. That is, they were issued for legitimate medical purpose and usual course of professional practice. And the doctors were doing the same thing. They were just prescribing without a legitimate reason for prescribing. There was no medical determination made. It was a major breach in the system. But because of law enforcement's focus on that problem, and then Congress coming in and passing the Ryan-Haight Act, we basically shut down that system. Unfortunately, that system moved back to Florida and turned into pain clinics, and pain clinics grew. Now, these pain clinics, besides the fact that they're operating illegally, they're doing the same thing that the Internet pharmacies did. The only difference is, in Internet pharmacies, there was no face-to-face visit. In pain clinics, they actually see patients. But again, the doctors are moving huge amounts of prescriptions out the door. Pharmacists are not checking the validity of those prescriptions. They're not ensuring they're valid prescriptions. And the wholesalers and distributors just continue to ship large amounts of drugs to those pharmacies without doing due diligence, without knowing their customer, without saying, well, why are you ordering? Why are you ordering this amount of drug when every other average pharmacy in the U.S. only orders this, and you're 10, 12, 14 times more than that? They have a responsibility under the Act. They choose not to comply with that obligation. And we're fighting this problem through education and regulatory control and enforcement. Since 2005, we have a distributor initiative that's educated distributors of their obligations under the Act. When distributors fail to adhere to their obligations, DEA takes administrative or civil action against their registration. From mid-2010 through the end of 2011, we took action against 5 wholesaler distributors for unlawfully supplying Florida-based rogue pain clinics or associated pharmacies with controlled substances. These actions included the issuance of immediate suspension orders and result in the restriction or loss of DEA registrations. We also focus our resources on practitioners that issue those prescriptions not for legitimate medical purpose. These practitioners feed the addiction of drug seekers and allow drugs to enter the illicit market and facilitate overdose and death. Rogue practitioner activity is not limited to Florida. In fact, rogue pain clinics are moving northward, and they operate in Georgia, Tennessee, Kentucky, and southern Ohio now, in addition to out west. A DEA investigation with state and local and federal agencies of a pain clinic doctor operating in Portsmouth, Ohio, culminated this February with the doctor being sentenced to 4 life terms for overdose deaths of 4 individuals. I'd have to wrap it up here, but we're making progress. DA is using its regulatory authority to ensure compliance with the CSA, and it's implementing regulations. These measures that we're taking are beginning to show promise. We're strengthening the integrity of the system through registrant compliance. In closing, I want to assure you that DEA is working closely with all of our counterparts, federal, state, and local, and our regulatory counterparts. As part of the Administrator's comprehensive approach to combating prescription drug abuse, we're committed to balancing the need for diversion control enforcement with the need for access to these important medications by legitimate users. Thank you for this opportunity to appear, and I look forward to answering your questions.
Thank you very much. I'm going to recognize myself for 5 minutes of questioning, and I would like to begin with Attorney General Bondi. And I know you care passionately. You and I have spoken about the opiate babies.
Yes.
And, it's my belief that when people dabble with heroin or cocaine, they understand they're dabbling with a potential addiction. They don't necessarily think that when they start playing around with pharmaceuticals. Can you speak to why you're so focused on the opiate babies? I mean, you really are passionate about it, and I'd love for you to, you ran out of time, so please talk about it for a little bit if you could.
Absolutely. Right after we passed our legislation last session, I started getting calls from neonatal intensive care nurses, neonatologists, and said, there's another problem, and you've got to come see this. I went to St. Joseph's Hospital in Tampa. 20% of the babies going through the neonatal intensive care unit are born addicted to prescription drugs. Now, imagine the worst addict you can see on TV going through those withdrawals. That's how these babies are born into this world. Their incubators have to be covered with blankets. They're sensitive to light, to sound, to touch. Instead of milk, they're getting morphine or methadone. That's how these kids are coming into this world. All Children's Hospital in St. Petersburg, that's a premier hospital for children. 30% of the babies going through the neonatal intensive care unit born addicted to prescription drugs, and it has to stop. Take it from a cost perspective. I take it from a life perspective, babies' lives, but if you look at it from a cost perspective, St. Joe's had to expand their NICU just to accommodate these babies. So it's costing taxpayers a fortune. And I think a lot of it really has to do with education, and that's why we have legislation proposed this session. I've talked to adoption lawyers, I've talked to nurses, we've brought in the Board of Health, we've brought in the Board of Medicine. It's all about working together to educate these women. Because unfortunately, I think some of these women will say, I've stopped drinking alcohol, I've stopped smoking marijuana. But because it's the word prescription drugs, they don't realize the harm that it's doing to their unborn child. What scared me to death, Chairman Bono Mac, was when I asked a doctor, I said, we can't let this become the next crack baby epidemic. And he said, we've already surpassed it.
Well, I thank you. I just wanted to say we don't even know the long-term consequences for these opiate babies. And I just want to turn, with my limited time, to Mr. And we hopefully will have a second round of questioning, but Mr. Ranazisi, you and I have had multiple discussions, and we're not always on the same page. But I applaud some of your efforts recently. You and I have talked about quotas. If Florida is having success at shutting down their pill mills, wouldn't the quotas show a correlating reduction in the quotas that you do allow in the manufacturing of these drugs? Are you seeing that?
Actually, we are seeing a decrease somewhat in Florida, but we're seeing the expansion of these pill mills throughout the country. If you go to Tennessee, Kentucky, Southern Ohio, and I know that most of those in Southern Ohio were shut down, but we still continue to see those flow out. And I just right now, even though Florida's on the going downhill, states north of Florida are starting on the rise. This problem is just moving north and west.
Well, I'm just glad to hear you admit that and to say that. That's encouraging to me. But can you speak briefly about the Cardinal case? Now that the district court has dissolved the temporary restraining order, what are the next steps in the Cardinal case? And apparently Cardinal plans to appeal. If the district court's order is upheld, what is the next step?
Because that case is in active litigation, I'm not allowed to answer questions. However, I can tell you we've had cases similar to Cardinal in the past, in the last 2 or 3 years. They're exercising their appeal rights, and we respect that. We will continue on with this program, looking at our distributors, making sure that they meet their obligations under the Act, and if they don't meet their obligations under the Act, we will take the same action that we've taken.
I'm just encouraged because long ago you and I argued that it was all coming out of Grandma's medicine chest. Correct?
Yes, ma'am, and not that I don't still believe it's coming out of the medicine chest, but I believe that we're handling it upstream now to prevent it from getting down to that level.
Thank you for that. Mr. Haslam, you talk about shipments, whole cargo containers that go missing, but they're unreported. Do you want to speak to that?
Anecdotally, law enforcement throughout Ohio has told us that cargo shipments are falling off the trucks. We've heard
Just magically.
magically.
Yeah.
We've heard through conversations with manufacturers about their security measures, and they do seem to be very good security measures, as Director Kurlikowski alluded to earlier. However, there seems to be a point as it gets further down the chain that the security measures either weaken or are not as efficient, and once it gets to the distributors and then they send it to their distributors who send it out, there appear to be security measures that aren't in place that allow shipments to fall off of trucks.
Thank you very much. My time is up, and I would like to recognize Mr. Butterfield for 5 minutes.
Thank you. Let me go to the gentleman from the DEA. How do you pronounce your name? Is it Ranazizi?
Ranazizi, yes.
Yes, all right, thank you. Let me talk with you about the security procedures followed by the prescription drug manufacturers, specifically how the drug moves from raw materials to usable medicine, then to distributors, and then down to the wholesalers. Are you comfortable, sir, with the security mechanisms employed by these companies?
The physical securities for the most physical security systems for the most part I am. We do on-site inspections every 3 years or so for manufacturers, importers, exporters, any of the raw material holders, and if there is problems in the physical security, we handle it on site. We make suggestions, and generally it's corrected.
Right. What kind of relationship does the DEA have with the prescription drug industry? Specifically, what programs does DEA employ to educate DEA manufacturers and distributors? How closely, if at all, does DEA audit or approve security measures employed by the manufacturers and distributors? And is there a difference in procedure for authorized distributors versus secondary distributors?
Well, first of all, we're on site to these distribution and manufacturing facilities every 3 years. In addition, for instance, the wholesalers and the distributors, we have a program called the Distributor Initiative, where we sit down, not as a group, but individually with each company, and we go over their distributions, and we talk to them about what to look for when they're sending their drugs downstream. We offer them assistance to help them identify what diversion is and where it is, and that's done individually by company. The manufacturers, we have an open door as far as the manufacturers go. I don't think we've ever had a problem with the manufacturers where we haven't rectified that problem. So we are regulators. We have a relationship between regulators and the industry, and we oversee them and make sure that they're operating under the Act, in compliance with the Act.
Right. Technology advances have enabled new abuse deterrent drugs to take the place of conventional pills. I am encouraged by the addition of abuse deterrent drugs into the marketplace, and while it's not a silver or magic bullet in completely stopping prescription drug abuse, it seems to be a tool that can greatly help. Some medications have been reformulated to be extremely difficult to crush and dissolve. And these are what we call abuse deterrent drugs, and new additions to the prescription drug marketplace, and have not yet been widely adopted, but things are moving in the right direction. Question: how do you think abuse deterrent formulations will have an impact on reducing opiate abuse, and how do we ensure that those who are addicted to not just switch to a new drug such as phenol or heroin?
I think that the abuse, well, first of all, we're very supportive of abuse-resistant formulations. We think that is the future that will curb drug abuse. However, we also know that abuse-resistant formulations tend to stop drug abusers from ingesting the drug in certain manners. For instance, injection or snorting the drug. When they need to, they take it orally. And abuse-resistant medication generally does not affect how you take it orally. What we're seeing in the field is they're taking the drug orally with an agent that'll give it a synergistic property to enhance the, for instance, for a drug like oxycodone, they'll take it with an alprazolam product, or carisoprodol, which is a muscle relaxant, to enhance the effects of the product.
All right. Thank you. You're back.
Thank you, Mr. Butterfield. Mr. Harper, you're recognized for 5 minutes.
Thank you, Madam Chair. And if I could, Mr. Ranazizi, if I could ask you a few questions. First, what regulation does DEA have that specifically outline the legal requirements that pharmacies, distributors, and manufacturers are required to take to avoid drug diversion?
Well, for starters, pharmacists are held pretty much to the same standard that doctors are under 1306.04. 1306.04 says a prescription is not valid unless it's issued for a legitimate medical purpose in the usual course of professional practice. It also goes on to say that a corresponding responsibility exists with the pharmacist to ensure that the prescription is valid.
Okay.
The manufacturers under 1301.71 and 1301.74 have to maintain a system that stops diversion, or the diversion of controlled substances into other than a legitimate marketplace. And it also goes on to say that you also have to maintain a system of suspicious ordering monitoring. And they leave it up to the manufacturers and distributors to determine how to set up that system of suspicious order monitoring.
Right. You know, I know DEA has the ability to see unusual ordering patterns. Are there certain thresholds or levels that you pass on to the distributors to look for? Are you giving them guidelines that you pass on?
No, I think what distributors have to do is look at their customers. They know their customers. I don't know all of their customers. They do. If they went on site and looked at their customers, they could make a determination of what thresholds should be maintained for those individual registrant customers. The problem is I don't believe that the distributors and the wholesalers are actually looking at their customers as closely as they should. If you have customers that on the average purchase, 70,000 oxycodone tablets a year, and you have customers purchasing well in excess of 1 million a year, I think that would trigger something where you should go on site and find out why. And I think that's the issue.
Does the DEA have those volume parameters that it uses but are not shared with manufacturers or distributors?
No, we don't share. We don't give them volume parameters. That's up to them. It's their system that they're setting up.
All right. Well, what guidance has DEA provided to the manufacturers, distributors, pharmacies, or whatever, on the specific steps that they should be taking to identify fraudulent prescriptions? What advice are you giving them to look for, or suggestions?
Well, there's certain red flags. Okay. For instance, a pharmacy. If you're sitting in, we'll say, Portsmouth, Ohio, and all of your customers are coming from 80 or 100 miles away, and the doctor you're filling for is 100 miles the opposite way, and it's all cash transactions, and you're seeing this over and over again, I'm not the smartest guy. Red flags pop up in my mind when that happens. Yeah. And I think those are typical red flags, and Attorney General Bondi, I'm sure any one of these distinguished gentlemen could tell, they're seeing the same thing that I'm seeing. So over and over again, we see these red flags. The pharmacist should see them too.
Would you favor, under the Controlled Substances Act, to create a stricter requirement, legal requirement for the most problematic drugs?
I think the requirements that are in place right now for these drugs are fine if the individuals within the supply chain and healthcare delivery system would follow them. The problem is that the doctors continue, not all doctors, 99% of the doctors are perfect. It's that small percentage of doctors that just don't want to fulfill their obligation. What they do is prescribe for illegitimate purposes, or they don't make a medical determination. They just go with patient-directed prescribing, which is just wrong. I think that if everybody within that supply chain would just police each other, we wouldn't have the problem that we have right now.
Thank each of the witnesses for being here today and for your insight. And with that, I yield back.
Thank you, Mr. Harper. Mr. McKinley, you're recognized for 5 minutes.
Thank you again. Let's go back to Florida, or maybe Kentucky, but let's start with Florida. When you have your program, your PDMP, do you have an identification system? Is that how, in part, is that included in it?
We, as I'm sure you're aware, we had some very difficult problems getting our PDMP in place, our prescription drug monitoring program. It was, 48 states have a PDMP, but many weren't up and running, and ours was one of them. We received some resistance. What we have done now is that it's up and running. We had some issues with getting it funded. So who came forward?
That's not what I'm asking. Do you have an identification? So when someone comes in, is this do they enter their name or something into a file?
Yes. And
so if they enter their name, and it's available for everyone in the state of Florida.
Absolutely. And it used to be 15-day reporting, and now we have limited that down to 7-day reporting. So we've shortened the reporting period.
So if it works in your state, why wouldn't that work nationally?
Well, and this is, like I said, brand new in our state because it had never been funded. So now it's funded by forfeiture funds from our sheriffs for the next few years.
What about Kentucky? What are you doing in Kentucky? Do you have the database of names?
We have the database, and what happens in Kentucky, we were one of the first states to bring a PDMP online, Congressman. But our doctors will go in and enter a patient name to see if that particular patient is doctor shopping. The problem we have in Kentucky is it's a pretty good system, but only about 25% of our doctors are using it. It's not mandatory. It's not mandatory that ER docs, for example.
Okay, that could be great. What concerns me some is you've done a great job in Florida, but you just chased them to another state. That's what I'm hearing from the other testimony here, and what we're hearing from around the country is that you did a great job. It happens in law enforcement when you start performing your duties, they go someplace else because they're not going to change their behavior. They've just transferred to another state. So I'm looking to see how we can capture them nationally.
And we still have a long way to go in Florida, but I think what we're doing is we're working together, and as long as I can tell you the two of us are still alive, we're going to put these guys out of business. I mean, we work together constantly. We share ideas, we share thoughts, and we, frankly, in Florida, we work great with the DEA. You have to work as a team. And I don't know if you were here earlier for that part of it, but you have to bring state, local, and federal authorities and now wrap all of our states into this because this is a national crisis. And, I mean, we are in a war with drugs, and it's just the drug has changed.
If I may address that point, Congressman, not to take up too much of your time, but Kentucky borders 7 states. And the pharmacists, when they fill a script, enter the data that goes into the system that doctors later check. The problem for us has been that the docs feel like it's too time-consuming. The docs don't want to be forced to do this, and they don't have a system that they think is user-friendly that they can type in, takes 30 seconds or less, and tells you if you're in eastern Kentucky whether or not this patient's been to West Virginia, Ohio, or Virginia or Tennessee. And that's what we don't have. And really, a state like Kentucky can't get to where we need to be. We can't get 50 states with a good system that's interoperable unless we have the help of the federal government.
In Ohio, do you have the names up on? Do you have with your program? Do you have the names of the individuals so we know what prescription drug they're acquiring?
We do, Congressman, and our program's been up and running for many years as well, just as Kentucky's has.
Do you see a problem with that going nationally?
I don't. I think it's one of the necessary tools that we're going to need to fight this epidemic.
How do you deal with the privacy matter? Because that seems to be the hang-up of the confidentiality of people accessing. How did you get around that for the state of Ohio?
Well, it is very protected by our Ohio State Pharmacy Board houses that program, and they're very protective over the information and who it goes to and how it's distributed, and that's how they get around it. They make sure that it is protected but it's a necessary tool in this battle as we move forward.
So you're just saying some states, here, 3 states, you all have that. You're doing something along that line.
Oh, the information's protected. Only the doctor is going to see it. And if we have a designated case open on a specific target, we can ask to see the CASPER data. But one of the problems we've seen is that the Board of Medical Licensure, when they see disturbing trends, are not forwarding on to law enforcement. We have that problem in Kentucky.
That's the same issue in Ohio, Congressman. It's a great tool. It's underutilized by our physicians. House Bill 93 required physicians that are treating pain management to utilize it. But as exactly as you've alluded to, as we have success in law enforcement, we're squeezing the balloon and people are just moving to other states. And what's happened, the 3 states represented here today have all worked wonderfully together to tackle this issue and to share that information in investigations.
I know difference of time. I think you're great models to it. I just want to see it replicated in all 50 states so that we can protect this thing. We can't have you operating independently. So thank you. Yield back my time.
Thank you. And Dr. Cassidy, you're recognized for 5 minutes.
Thank you, Madam Chair. First, I'll say that we're introducing Mike Ross and I from the other side of the aisle, H.R. 4095, which is the Stop Online Pharmacy Safety Act, which attempts to close down or at least prevent the publicizing of these rogue pharmacies. So hopefully we'll get some co-sponsors on this. Secondly, Mr. Nazi, man, I keep on thinking with the databases y'all have, if we gave them to Google, I have no doubt that Google knows what color dress my daughter has on today. And so it seems like data mining could really go a long way to pinpointing these problems for a specific intervention. I'm told by industry that y'all have lots of data forwarded to you regularly. My question is, why not?
I think the data they're referring to is our ARCOS system.
Yes.
Yeah, under 827D, they're required to send all narcotic controlled substance transactions to us to be put in a database. And we do have that information. And quite frankly, we use that information to assist us in investigations. However, that information is proprietary. It's protected information. I can't release that information to industry, and they've asked before.
But you could release it to local law enforcement.
If local law enforcement is involved in investigation and they request the information, yes, we can.
Let me ask, because as I go through the testimony, you have rank-ordered states in which there is the highest prescriptions per capita of controlled substances. You've related it to over 65, how many people in Medicare Part D are getting X amount per in a certain region. I also see other statistics where you speak about 3 or 4 physicians moving from one state to another, so you have physician level. And I'm sure you also have pharmacy level. It just seems, again, if Google had that, or some other data miner had that, we could have a specific intervention here, boom, and then there, and then there. It seems like there's missed opportunities. What am I missing on this?
I don't believe there's missed opportunities. The data that we have is very narrow. It's for the narcotic controlled substances. For instance, I'm dealing with a pharmacy or a group of pharmacies and manufacturers or distributors that are selling phentermine or alprazolam or drugs like that. I have no way to track it because it's not entered into the system.
But if we just took those which are narcotics, I mean,
Yes.
Probably there's going to be a correlation between somebody getting an illegal prescription for Ativan as well as an illegal prescription for OxyContin. So I'm not saying you have to do the breath, but again, if you have reported to you the narcotics for OxyContin, again, knowing that you, just from here, have a heck of a lot of data, why aren't we doing every week another intervention at another pharmacy? Because it seems like it's a target-rich environment.
Oh, but we are. We have active investigations across the country based on complaints and our ARCOS data. Now, sometimes the ARCOS data, it might show up with a pharmacy that is indeed a legitimate pharmacy that does have a high volume, and the reason they have a high volume is because they're next to a hospital or oncology clinic.
And that's a fair statement. I can imagine a crosstab which would say, okay, here are the variables that we find associated with I just, again, see Google with an algorithm, which again, which would data mine. Are y'all data mining on that, formally data mining?
Yes, we look at that. We look at ARCOS data on a regular basis. We look at the top 50, top 100 in different areas of the country. We make sure that we do background to make sure those pharmacies and wholesalers are operating within the confines of the law. And if we have further information on it, we open investigations. Yes, that's what ARCOS is for. ARCOS is a targeting tool.
How many active investigations do you all have right now?
I would have to get back. I don't want to throw out a number.
Ballpark 50, 100, or 1,000?
Oh, we have a lot. Many more than 1,000.
Okay. Now, kind of a recurring theme from these folks is that people go from one state, they go to another. I live in Louisiana. My pain docs who are legitimate tell me that illegitimate patients, if you will, go to Mississippi or Houston and then back again. So is federal, in your mind, is federal legislation required that would almost mandate some sort of standard so that Texas, Louisiana, Mississippi, Arkansas, or Kentucky, with every state bordering it, would be in some sort of interchangeable information?
I think, well, my personal opinion is yes, I'd love to see that because I think doctors need that additional tool. I think as a practitioner you would agree that I want to know what my patient's doing and who my patient's seeing, whether it's in Kentucky, Ohio, or 4 states over. The problem is interconnectivity, and the problem is a lot of these states have different state laws and different laws regarding the information and how it could be distributed. So I don't think it's I think the problem lies within the states. They have to work it out. This is not a federal government system, and while we support the states and we want the states to get that interconnectivity, that's a question better asked to the states.
Just if I may have 10 more seconds, I will say that after Hurricane Katrina and all my patients were displaced to other states, I found that there was something that happened. A switch was turned, and a doctor in Oklahoma could find out the drugs I was prescribing for my patients in Louisiana. And so it does seem as if that interoperability could occur in a fairly straightforward fashion if we had, a little direction.
Yeah, I remember that, and the state boards were working extremely well together, and I don't know how that information was passed because we don't have dispensing information, but I do know that we were working with the state.
I think it was through e-scripts.
Yeah.
I think that there was something like that.
But the state boards really came together, and they did a fine job getting everybody.
So there's a chance we just need these folks to talk to their state boards.
Yeah.
Okay, thank you. I yield back.
Thank you, Dr. Cassidy. Chair recognizes Ms. Blackburn for 5 minutes.
Thank you so much, and I want to thank you all for your patience today. As you know, we've had other hearings downstairs. We had Secretary Sebelius in looking at the budget that is there, and I know that those of you at the state level are quite concerned about the Obamacare impact that is coming to a state near you very quickly. Mr. Ranazizi, am I saying your name correctly?
Yes, ma'am.
I'm close enough, huh?
Perfect.
Okay. On the Ryan Haight Act, how many online pharmacies have registered under that act? How's that being built out?
Currently, we have no registered pharmacies under the act. We have, I think, 4 or 5 applications pending, but no pharmacies have been registered. Now, remember, there are a lot of provisions in the act that allow you to do certain things online. The act was written so it would prevent the rogue pharmacies from jumping online and continuing practice, and it has done that. There's no domestic pharmacies currently that are operational that are under
Okay, then let me ask you this another way. How many enforcement actions has DEA taken against online pharmacies or rogue pharmacies under the act?
I have to get back to you, ma'am. Very
Okay.
few, because the act pretty much shut down the domestic online pharmacy problem, and the problem moved overseas.
Okay. Are you having difficulty in sorting and finding out which are the rogue foreign-based pharmacies? Or I would like to visit with you more about that. I think that it is an issue that is a concern to us, and being able to see where we have these online pharmacies, find out who is registering or not, that would be helpful and instructive to us. So let's look at that a little bit, and then if you could quantify the kind of actions that have been taken against some of these rogue pharmacies. It allows us to do a little bit of due diligence and see if decisions we're making are working or having an impact or not. So I would appreciate having that time with you. I want to talk with you for just a little bit, and if you can answer this within the allotted time, that's great. And if you need to get back to me, that would be great. I'm no cheerleader for the FDA, but I understand their philosophy and approach that an agency, as it applies to control substances, seems much more measured than that of the DEA at times. And my understanding is, I want to talk about this post-inspection feedback in the form of what's known as the FDA Form 483 inspection report. And my understanding on this FDA Form 83 is that it sets out with specificity the agency's concerns, and the parties have the opportunity to meet with the FDA and discuss any issues that may be before them, that companies are given the opportunity to address issues and solve problems in a collaborative dialogue. And if the company were to choose not to address the issues, the agency then typically takes further action in the form of a warning letter and proceeds with prosecution and consent decrees as appropriate. And I think that FDA type approach is different from the DEA approach when there are problems, which is just enforcement and not the opportunity to address concerns. So it seems like DEA, there is no post-inspection give and take or dialogue that may be there, and no information sharing or the opportunity to address issues or that are out there. So my question to you is this, and you mentioned Tennessee as one of the states with the pill mills, and we all are concerned about patients that are in pain, that need medication, that companies that are trying to meet those needs, and here again want companies to do the right thing, want them to spend the money wisely, want individuals to be safe, want there to be protections that are in place. So my question is there a more surgical approach? Should we be thinking of a more surgical approach to addressing the issue of prescription drug abuse rather than just looking at suspension of licenses? Where's the right balance in a vetting process? Is there a more proportional approach to take rather than just going to an immediate suspension?
Yeah, I would love to answer that question. First of all, the FDA deals mostly with legend drugs, and they do have manufacturing processes. They look with controlled substances, but the vast majority of their authority is over legend drugs and prescription drugs, making sure they have good manufacturing processes, maybe making sure that labeling is correct, putting through the drug through the appropriate validation process. My responsibility under the Act is to ensure that there's no diversion of highly addictive medications into the illicit marketplace. We do give chances to companies. If you look at our history, we went on site on many of these companies that we've taken action against, and pharmacies, and explained to them what their obligations were. We sat down with them and talked to them about what their obligations were. They just
okay, so your response then would be that you all are carrying out that dialogue?
Yes.
Okay. All right.
I look at Florida and the millions of tablets that are going into the illicit marketplace in Florida, not only from the pharmacies, but also from the distributors and the doctors. And I think we have to hold the line somewhere. These are drugs that are killing people. It's not amoxicillin. And, we have to take a stand.
Okay. Do any of the others of you want to make a response to that? No? Okay. Madam Chairman, I'll yield back.
Thank you, and I'm going to recognize myself for 5 minutes for a second round, and any other member who wants to ask a second round, I will yield to you for your own 5, and then we'll move to the third panel. But first of all, my comment on what Dr. Cassidy had to say, I think he brought up a good point, and I think it's fair to ask if the DEA data mining capabilities are as robust and clever as you would suspect Google's are, and perhaps we can visit that in the days ahead. But this is a sort of a general question to each of you. And thank you, Mr. Ranazizi, for mentioning my support of your take-back days. But 995,000 pounds of drugs in 3 days. The question I want to ask each of you, if you care to comment or weigh in, is who's paying for those pills? Are we paying for them in the form of health care premiums? Are we paying for them through diversion out of Medicare Part D and Medicaid? Who is paying for all of those pills? Why are there 995,000 pounds of extra pills being turned back in? What is the overall toll in health care in our country just from this problem? Anybody?
I can tell you from our local take-back days, these are good, solid citizens who are coming in with brown paper bags filled with prescriptions that they've had and that they're concerned because they know you cannot flush prescription drugs down your toilet, and they don't know what to do with them, and they don't want their grandkids to get a hold of them. And you know, when I speak to people, I say, no one ever wants to believe it's their kids, so I say your kids' friends can get into your medicine cabinets. So people, it's our citizens, and I think a lot of them are getting them from their doctors, their dentists, for legitimate purposes. They're taking one or two of them and they're just stockpiling them because they don't know what to do with them. But we have had remarkable results with good citizens turning them in to have them properly disposed.
But the question is why are there so many left over in the medicine chest to turn back in? Who is paying for it? What is the cost? And General Conway, you mentioned this is an American tragedy, and I couldn't agree with you more. There's no question our doctors are working too hard. And ultimately, this comes out of their patient visit. They're scrambling because health care is squeezed more and more and more, and this is a part of the problem. But $148 million diverted out of Medicare Part D in 2008 alone. So are we really, I mean, General Conway, you want to weigh in on?
Well, I don't know that I can quantify the cost. I mean, sitting here as the Attorney General of Kentucky, I can't quantify the cost, but my experience is similar to General Bondi's. So when I go to one of our drug take-back days and sit there with my plastic gloves on, it's a concerned mother who doesn't want her kids or realized she saw something on TV and her hydrocodone she got for a broken arm is expired. The cost comes in crime. People are committing thefts to get access to resources to buy pills. The cost comes in cash. A lot of these pill mills deal on a purely cash basis. When you have healthcare companies that are trying to get more efficient and mandating 90-day supplies of some of these mail-order pills, a 90-day supply in Kentucky of hydrocodone or oxycodone, chances are about 50% of that's hitting the streets. That's what my law enforcement officials are telling me. That's something that we need to quantify. And certainly Medicare and Medicaid are paying some of that.
And Chair Bono Mack, I think what you're saying is if you go in for routine dental surgery, why do you need 60 oxycodone
Exactly.
pills? You don't.
Thank you. Thank you. And Mr. Haslam, you speak on this to this in your testimony too. You suggest that maybe they have sort of a tiered approach into needing their drugs. Do you want to speak a little bit about your beliefs on this too?
Absolutely, Madam Chairman. What we see in Ohio, we see, to answer your original question, the taxpayers at some level is paying for the problem. No matter how you look at it, when you boil it down to the common denominator, it's the taxpayer that's paying for it, whether it's Medicaid costs in Ohio, especially in southern Ohio, which is economically depressed. It borders eastern Kentucky, as we've heard Attorney General Conway allude to as an economically depressed area. That it's a huge burden on the Medicaid system there. And as you move across the state of Ohio, though, it's not limited to that socioeconomic class. It goes all the way to the middle class up to the upper class. And whether it's a company that has to pay increased healthcare premiums that it's providing for its employees because of the number of pills their employees are receiving as part of a prescription, or the insurance companies, the cost to those folks. The insurance companies in Ohio have recently reached out to the Attorney General's office to talk with us and say, what role do we play in this? This is a huge cost to our bottom line. It touches everybody. So at the end of the day, it's the taxpayer that's footing the bill for this prescription drug problem and for those large amounts of pills that are on the street.
Thank you. So when we win the day with the arguments of the human suffering, of the budgetary tolls, there's no rhyme or reason why we wouldn't be tackling this head on as a nation. And again, Mr. Ranazizi, one last question to you. This committee has been investigating nano encryption and taggants and other technologies coming out. Can you speak briefly about future technologies that you might be exploring like this on tracking drugs?
Ma'am, if I can take that question for the record, I'm not an expert on
Okay.
tagging, but I do have experts on staff.
That's fair. You know, we will be submitting plenty of questions to each of you for the record. Mr. Butterfield, did you have a?
I have one.
All right, I'll yield to you for
Thank
5
you.
minutes.
Thank you. Under the careful supervision of a doctor, prescription drugs can alleviate severe pain or help those suffering from mental disorders like psychosis or depression or anxiety or insomnia or attention deficit disorder. Unfortunately, there are true stories of these drugs being prescribed inappropriately or not for their intended use. Only 54% of physicians ask about prescription drug abuse when taking a patient's medical history, and only 55% regularly contact a patient's previous doctor before prescribing controlled pain medication. Question: state entities certify and regulate both doctors and pharmacists. Through this role, General Conway, what do you think state authorities can do to educate medical practitioners?
Well, the thing about the medical community, Congressman, is that it's not a one-size-fits-all approach. And we have a piece of legislation we're considering right now in the General Assembly that I'm supportive of that would require anyone who wants to prescribe a Schedule II or III narcotic to mandatorily register with our PDMP. But I think that the education component for the medical community is important. The chairwoman talked about what needs to happen with short-term prescriptions. Our ER docs need to have standards for how much should they prescribe if someone shows up at the ER. They ought to do mandatory PDMP checks. The problem for us in law enforcement, and in Kentucky, and I can't speak to it in other states, but in Kentucky, we have a little bit of a battle with our medical community in that the CASPER system, our PDMP, is housed over in a cabinet of Health and Family Services. They have the data. They observe the trends that are problematic. They are supposed to take actions against licenses if they spot problematic trends and then refer them to law enforcement if necessary. Until this issue received increased scrutiny here in the last couple months, in my first 4 years as Attorney General, I didn't have a single law enforcement referral from the Board of Medical Licensure. So the doctors, if they're going to be prescribing, you know, there are different standards for an oncologist or a pain management doctor from a podiatrist and an allergist. But the doctors that are going to be prescribing have an obligation to use the system, to check their patients, and to help us police their profession, because they're underutilizing the system right now, and they need to work with us so that we can see the data. I cannot ask who are the 2 largest prescribers of Schedule II and III narcotics in Pike County. I'd love to, but the law prohibits me from doing it, and the Board of Medical Licensure is not sending me the data. So I'm using old-fashioned surveillance and talking to people about where they're getting the pills in order to figure it out. And we have a great system, and all the data is right there. We are just underutilizing it. And we're underutilizing it because we don't have the partnership we need with the medical community to make certain that that's getting addressed in Kentucky.
Would it be helpful to work with some of the medical schools, the dental schools, to develop a curricula in this area?
Oh, absolutely. I speak to the pharmacy students, and I speak to a lot of medical students on an annual basis to tell them how big the problem is and to look out for this. You know, it's a balance here. The medical community gets nervous whenever an attorney general or a lawmaker gets in the middle of the doctor-patient relationship, and I respect that. But there ought to be some way for us to see the disturbing trends so that we can do our job in law enforcement. Right now in Kentucky, our data monitoring law says I have to have a designated case, a bona fide case open on a designated target. I can't look at trends. I can't see where the problems are. I have to ask about Mr. Smith. And the data's all there, and I can't use it, and I can't tell you how incredibly frustrating that is.
Do you believe the federal government should consider certain minimum standards for doctors, for doctor education or training in the area of addiction medications?
I don't think it's a bad idea. Traditionally, the regulation of the practice of medicine has been left to the states. I respect that. I think we're doing all we can in the Commonwealth of Kentucky to educate doctors. A lot of the healthcare organizations are starting to set up, some of our larger hospital companies are starting to set up standards for their ER docs. I think that's great. I think it's something probably best left to the states, but I'd welcome some federal guidance on that.
All right, thank you. I understand you may have spent some time at Duke University.
I did, sir.
Right.
I did, sir, and I don't know your allegiance. And one of the toughest things I have to do is get elected statewide in the Commonwealth of Kentucky, being a graduate of Duke University. It's basketball passions being what they are.
My state legislature's just added Duke University to my district.
Well, Roy Cooper and I have a running argument every time we see each other, and I'm going to see him this weekend. I'm sure we'll be arguing over that little game this weekend.
All right. Thank you.
Thank you. Mr. McKinley? No? Okay, well, the next panel. Okay, we want to thank you all very, very much for your expertise and your hard work on this. We look forward to working with you. Please anticipate further questions in writing. We look forward to getting your responses. Again, thank you for fighting this battle. We look forward to partnering with you in the future. Safe travels home.
Thank you, Chair.
Thank you.
Thank
And we'll take a quick 30-second break while we seat the next panel.
One more to go.
You know what, I was
extremely upset with you.
On our third panel, we have 5 witnesses. First is John Gray, President and CEO of Healthcare Distribution Management Association. Our next witness is John Harmison, a pharmacist and owner of DFW, sounds like Dallas-Fort Worth Airport, we're just talking about. Oh, it is, okay. Of DFW Prescriptions, who is testifying on behalf of the National Community Pharmacists Association. Hopefully I'll be flying through DFW later today. We also have another pharmacist joining us, Kevin Nicholson, Vice President of the National Association of Chain Drugstores. Next is Kendra Martello, Assistant General Counsel, Pharmaceutical Research and Manufacturers of America. And our final witness is David Goff, Vice President for Regulatory Science of the Generic Pharmaceuticals Association. Welcome, everyone. I think you know the drill, the 5 minutes. There's the timer. With that, we'll be happy to turn to you, Mr. Gray, for your 5 minutes. Please make sure your microphone is on.
But now it's greener. Thank you. Good afternoon, Chairman Bono Mack and Ranking Member Butterfield and members of the Energy Commerce Subcommittee on Commerce, Manufacturing, and Trade. I am John Gray, President and CEO of the Healthcare Distribution Management Association, and I want to thank you all for the opportunity to come here today and talk about this critically important problem of prescription drug abuse and diversion, and most importantly, what my members are doing to combat that problem. The pharmaceutical distribution industry's primary mission is to operate the safest, most secure, and efficient supply chain in the world. As part of this mission, HDMA and its members are committed to addressing the serious national problem of prescription drug abuse and to being a part of the solution. HDMA members have not only statutory and regulatory responsibilities to detect and prevent diversion of controlled prescription drugs, but to undertake such efforts as responsible members of our society. To address the issue of prescription drug abuse, distributors have developed complex systems to help prevent diversion of medicines and to comply with the DEA's expanded expectation for suspicious order and monitoring and reporting. To aid the development and implementation of these systems, in 2008, HDMA and its member companies developed the Industry Compliance Guidelines to support the distribution industry practices on the evaluation of customer orders for controlled substances and the reporting of so-called suspicious orders to the DEA. The ICGs, as we call them, were vetted with the DEA in advance of the publication. These guidelines emphasize the concept of know your customer. That is, obtaining and reviewing thorough background information about a prospective healthcare provider prior to doing business with them. Therefore, in many cases, potential problems can be avoided even before an order is placed. Because the advanced systems now in place in the industry's proactive efforts, the EA reported last year that since 2006, 2011, distributors in this country stopped shipping controlled substances to more than 1,500 customers that could have posed an unreasonable risk of diversion. Let me add, it's critical that the anti-diversion efforts of our industry, as well as the enforcement actions of DEA, should always carefully balance the need to cut off supply to any customer engaged in diversion while not limiting access to appropriately prescribed and legally dispensed medicines for seriously ill patients or potentially putting legitimate pharmacies out of the business. Despite the best efforts of our industry, we find ourselves today in a conundrum. Pharmaceutical distributors do not manufacture legal controlled substances. We do not license pharmacies or healthcare providers. We do not write prescriptions for patients. We do not dispense these products to patients. We do not see the prescription a patient presents for filing at a pharmacy. A single pharmaceutical distributor does not know and has no way of knowing if a pharmacy customer is purchasing prescription drugs from other distributors. Furthermore, we do not determine or set prescription drug fill rates. However, the DEA receives information from each distributor that sells controlled substances to a particular pharmacy or prescriber. The agency also sets annual allowable production quotas for manufacturers of these controlled substances. Distributors are often held accountable with incomplete information for diversion from parts of the supply chain they simply do not control. To comply with the DEA expectations, distributors are being asked to judge the diagnosis, intent, medical knowledge, experience of doctors and pharmacists. Furthermore, the DEA's emphasis on volumes and national averages to determine suspicious orders may simply oversimplify the problem for Schedule II controlled prescription drugs. Our members have found the analysis of a single pharmacy's controlled substance ordering patterns is simply far more complex. It includes critical factors such as the size of the pharmacy, the patient demographics, the geographic proximity to the hospitals or surgery centers, nursing homes, cancer clinics, hospice providers, and other major urban areas. Now, as was stated earlier today, I need to correct that. We do not choose not to comply with these laws of suspicious ordered monitoring. The fact is our members have many questions about the compliance. You heard this is a relatively new process, a new procedure, and unfortunately today, with the questions we have remaining, each distributor essentially operates in an information silo. We are unaware that a new pharmacy customer may have been cut off by another distributor who had concern about potential diversion at the pharmacy, or we are unaware that an existing pharmacy customer is ordering controlled substances from multiple distributors. Or we are also unaware that specific pharmacies may be dispensing controlled substances for physicians who are writing prescriptions for patients when there is no legitimate medical need. So in an effort to break down these silo walls and get this new program going, HDMA has asked DEA in face-to-face meetings over the last several years, as well as in written communications, to provide some clarification and guidance on the agency's expanded expectations of an anti-diversion program for wholesale distributors, and we've sought greater information sharing in the process between the agency and our industry. Throughout these communications, HDMA and its members have also asked DEA to provide aggregated and critically important blinded data from the ARCOS system that could be used to further assess product orders and provide supportive information for the agency and for the members. A distributor does not have the independent ability to determine whether a pharmacy or a physician customer is ordering from multiple distributors. Only the DEA possesses that information. In closing, we strongly believe that all stakeholders, doctors, pharmacists, distributors, manufacturers, and indeed the government must work together to achieve this shared goal to ensure a sufficient, safe supply of medicines for legitimate patients while keeping those same drugs out of the hands of individuals who will abuse them. Mr. Chairman, thank you for your time.
Thank you, Mr. Gray. Mr. Harmiston, you're recognized for 5 minutes.
Thank you, Madam Chairwoman.
On and pulled close to you, please.
Does it help if I get it closer?
Yes, thank you.
I'm sorry, I have a hearing deficit and people say I talk too softly. Sorry. Good afternoon, Madam Chairwoman Bono Mack, Ranking Member Butterfield, members of the subcommittee. I'm Joe Harmison. I am a practicing pharmacist. I am a pharmacy owner and past president of the National Community Pharmacy Association. NCPA is a national organization representing the owners and pharmacists of the non-publicly traded community pharmacies. Everyone here today is in agreement that the United States has a problem with drug abuse, misuse, and diversion. I hope we will also acknowledge that the drugs we're discussing today, when used appropriately, are extremely beneficial. When they're not used as intended, they're destructive in many ways. Has been stated over and over, the majority of people that abuse prescription drugs get them from the family medicine cabinet or friends. This shines a very bright light on how we need a means to destroy these drugs. The community pharmacists in the United States have been excited, willing participants in the drug take-back program for destruction. The problem we have, we're not allowed to take back the controlled substances, or what those are the drugs we really want to get off the street. We can't handle that. We are anxiously awaiting the rules we have been told by DEA they are promulgating to allow us to participate in this process. The pharmacists of America interact with millions of patients every day and advise them on how to use their medicines correctly and what can happen if they don't. We cannot cure the problem we're addressing today by ourselves. We use the tools we have, but we need more tools. There have been many suggestions on how you can get more, or people can get more information to us. I am very much in agreement that the most readily implementable and procedure we have right now is the PMPs. Every pharmacist in, I believe it's been stated, 48 states has to submit on a regular basis the information on the controlled substances they dispense. This goes into some giant computer somewhere. The problem the pharmacists have with it is most of us don't have access to that information. It's certainly not in real time, and it's not able to be incorporated into our workflow systems. If you can find a way to get that to us, we will be your greatest advocates in using it. We do not want to be the drug police. We will be very willing to work with all parties to prevent abuse, misuse, and diversion. Another thing with this computer database, it must not be the deciding factor on whether a patient gets their medicine. That decision must be left to the responsible parties, the prescribers and the pharmacists. We're the ones that know the patients best. We know their conditions. Another very important part of this equation is pharmacy burglaries and robberies. In 2010, there were 686 armed robberies of pharmacies in the United States, and unfortunately some of these end up with murders involved with them. Unfortunately, I have way too much experience firsthand with pharmacy burglaries. One of my pharmacies has been burglarized 3 times since December 1st of 2011. This is one small pharmacy, and from what I can determine, the street value of the drugs taken from my pharmacy is in excess of $575,000. And more onerous than that, there were almost 10,000 doses of controlled substances potentially put on the street. I'd like to make a few recommendations for your consideration. 1, require mandatory minimum sentences for robberies and burglaries involving controlled substances. Find some way to give federal, state, and local law enforcement and prosecutors the ability to better communicate and coordinate their efforts to do their work. 3rd, shut down the pill mills. Get the bad actors out of the process. Leave those of us that are trying to do the best we know how, what we're trained to do, care for patients, to do our job. Another is consider a change to the tax code to allow those of us that have put out the money to have different security systems to depreciate those in 1 year. Don't make us depreciate it over 7, 10 or more years. And also, we would hope that you might reconsider allocating some of the money taken from forfeiture from crimes related to controlled substances, put that in a pot somewhere and let pharmacists apply for some of that money. If they can't afford security systems, let them apply to use some of that forfeiture money. NCPA and the community pharmacists in the United States are committed to working with Congress and law enforcement to combat drug use, misuse, abuse, and diversion, but we need your help. Thank you for the ability to be here today and your attention.
Thank you. Mr. Nicholson, you're recognized for 5 minutes.
Chairman Bono Mack, Ranking Member Butterfield, and subcommittee members, thank you for the opportunity to testify. My name is Kevin Nicholson. I am a pharmacist and Vice President of Government Affairs and Public Policy for the National Association of Chain Drug Stores. NECDS represents traditional drugstores, supermarkets, and mass merchants with pharmacies. Our members operate more than 40,000 pharmacies and employ more than 3.5 million employees, including 130,000 pharmacists. Our members are deeply committed to serving the healthcare needs of Americans. We are serious about the trust our patients impart upon us and about our responsibilities to provide the highest quality care. We are keenly aware of the scourge of prescription drug diversion, and our members actively work on numerous solutions. We also support a number of new and federal state policy initiatives. DEA has implemented comprehensive regulations for a closed system to minimize the diversion of controlled drugs. Our members have developed extensive policies and procedures to comply with DEA's regulatory regime and similar requirements from state agencies, such as boards of pharmacy and narcotic drug agencies. A complex regulatory and policy matrix of checks and balances protects Americans. Chain pharmacies have zero tolerance for prescription drug diversion. We have implemented a variety of extensive and robust loss prevention and internal security systems, from our prescription drug distribution centers to the point of dispensing to patients. Examples include that we conduct background checks and random drug testing, extensive DEA training within 30 days of hire, maintaining electronic inventories of controlled substances with random auditing, use of camera surveillance, closed-circuit television, heavy-duty safes, and complex alarm systems, training employees on how to handle suspicious prescriptions, and internally investigating unusually large drug orders. Chain pharmacies support and comply with state prescription drug monitoring programs. We support policies to prevent illegitimate Internet drug sellers from illegally selling prescription drugs to consumers, and we support efforts to provide consumers with the means for proper disposal of unwanted medications in ways authorized by law enforcement. NECDS is pleased to offer our support for the Online Pharmacy Safety Act, which would take important steps to shut down the illegitimate Internet sellers that prey on consumers. We applaud subcommittee members Bill Cassidy and Mike Ross for their strong commitment to protecting the American public. Approximately 36 million Americans have purchased prescription medications online without a prescription. Americans are being harmed by these rogue Internet sites daily. We also look forward to DEA's upcoming regulations to allow consumers to safely dispose their unwanted controlled prescription drugs. DEA recognizes that consumers' inability to safely dispose of controlled prescription drugs contributes to prescription drug diversion. NECDS routinely meets with DEA officials to learn about diversion trends and to develop strategies to mitigate and reduce problems. And although we support the mission and objectives of DEA, we do have concerns with DEA's recent policies surrounding the volumes of controlled substances ordered by pharmacies. Every pharmacy environment is different, and enforcement action should not be brought against a pharmacy merely based on the number of controlled substances ordered or dispensed. Certain pharmacy locations will have higher than average volumes of controlled substances. For the ultimate good of patients who rely on access to controlled substances for legitimate purposes, such as pain management, we urge DEA to take a holistic approach when developing policies to pursue enforcement actions. We have worked over the past few years to develop prescription drug risk management programs with FDA, called REMS, to reduce the potential for addiction and abuse of prescription drugs. And we will continue to work with FDA on future similar risk management programs. We also meet routinely with the White House Office of National Drug Control Policy on trends and solutions. We are proud of the comprehensive approach that our chain pharmacies have taken and look forward to continuing our work with federal and state policymakers to implement solutions, including expanding prescription drug monitoring programs, shutting down illegitimate Internet sites, and providing consumers with the ability to safely dispose unwanted prescription drugs. I thank you for the opportunity to appear and welcome your questions.
Thank you, Mr. Nicholson. Ms. Martello, you're recognized.
Thank you. Chairman Bono Mack, Ranking Member Butterfield, and distinguished members of the subcommittee. My name is Kendra Martello, and I'm pleased to offer this testimony today on behalf of the Pharmaceutical Research and Manufacturers of America, or PhRMA. Our members represent America's leading pharmaceutical research and biotechnology companies. Our prescription drug distribution system is a closed system. This means that all entities engaged in the manufacture, distribution, and dispensing of pharmaceutical products, including controlled substances, must be licensed, registered, or approved by FDA, DEA, or the states. Thus, each entity has a shared responsibility to prevent diversion of pharmaceutical products. When an authentic product is diverted, it could be mishandled and potentially cause patient harm if reintroduced into the legitimate supply chain. Additionally, a diverted medicine can be misused or abused. The Controlled Substances Act and DEA regulations require entities handling these products to register and to have in place effective controls and security measures to protect against theft, loss, or diversion of controlled substances. The DEA also has authority over websites dispensing controlled substances and recent additional authority to supervise return of unused controlled substances for disposal. PhRMA member companies engage in a variety of activities to help prevent diversion of their products from the regulated supply chain. Our companies take these efforts seriously because fundamentally, patient safety and the public health demand no less. Our members employ a range of measures to prevent diversion, from facilities security, including uniformed guards, fences, and extensive access control and video surveillance systems, to strict controls over in-process manufacturing operations, to in-transit security measures such as the use of GPS tracking devices on 18-wheelers that carry medicines across the country, to enhancing enforcement by information sharing with law enforcement officials, and to helping educate others on best practices. Our companies work to help secure the products they manufacture in the regulated supply chain. Because of the number of independent actors in the drug distribution chain, preventing diversion of medicines from the regulated supply chain is a shared responsibility. Recognizing this, PhRMA members participate in broad-based coalitions to help address specific aspects of prescription drug diversion. These include coalitions to increase penalties for cargo theft, groups to facilitate information sharing and best practices, and participation in stakeholder coalitions that are pursuing new authorities in a variety of related and significant areas. These activities are detailed further in my written testimony submitted for the record. We do believe that there are additional authorities that could also have a significant impact on reducing diversion, as well as reducing the non-medical use of prescription drugs. These include, first, increase the use of and improvements to state prescription drug monitoring programs, which can be an important tool to prevent and detect abusers and refer them for treatment. Second, reauthorize NASPR, which provides grants for these states' monitoring tools and which is legislation we've supported. Third, increase penalties for and enforcement against criminal cargo theft, rogue online drug sellers, and criminal counterfeiters. Fourth, fully implement DEA authorities over online sales of controlled substances and responsible, secure disposal of unused controlled substances. And finally, increase licensure requirements for wholesale distributors to prevent unscrupulous actors from moving their operations across state lines. In conclusion, PhRMA and its member companies are dedicated to improving the lives of patients. This emphasis on the patient extends throughout the product life cycle, from researching and developing new medicines, including abuse-resistant formulations, to helping ensure medicines are used appropriately, to helping prevent diversion from the regulated supply chain. At the same time, addressing the growing problem of prescription drug abuse is also a shared responsibility, and patients need continued access to the medicines they need to allow them to live longer, healthier lives. We remain committed to addressing the issues surrounding prescription drug diversion and inappropriate use of prescription medicines, and we look forward to continuing to work with the subcommittee, members of Congress, and other stakeholders on these important issues. Thank you.
Thank you, Ms. Martello. Mr. Goff, you're recognized.
Thank you. Good afternoon, Chairman Bono Mack, Ranking Member Butterfield, and members of the Energy and Commerce Subcommittee on Commerce, Manufacturing, and Trade. I'm David Goff, Vice President of Regulatory Sciences at the Generic Pharmaceutical Association and a licensed pharmacist. GPHA represents the manufacturers, distributors of finished dose generic pharmaceuticals, bulk chemicals, and also suppliers of other goods and services to the generic pharmaceutical industry. Generic pharmaceuticals now fill about 80% of all prescriptions dispensed in the United States, but consume just 25% of the total drug spend for the prescriptions. GPHA's member companies manufacture FDA-approved generic versions of brand name drugs in all therapeutic classes, including prescription painkillers. We share the concern of the members of the committee when medications that are made to improve the quality of life and alleviate pain are abused. We believe that addressing this issue will require continued coordination among federal agencies, state, local, and federal law enforcement, healthcare professionals, drug manufacturers, patients, and even the caregivers. And we will work together to shape policy to control the misuse of pain medications. We must recognize that the overwhelming majority of individuals, including millions of senior and cancer patients, rely on these important medications to help treat their pain. In our collective efforts to curb drug diversion, we must carefully, but not inadvertently, punish the patients who need these medications. Rather, we should punish the criminals who illegally acquire and sell these products outside the normal chains of distribution. GPHA member companies are absolutely committed to the safe and reliable manufacturing and delivery of generic drugs. As an industry, we have invested millions of dollars in technologies and delivery systems to help assure that our products reach their destinations safely and securely. For example, our industry works with the DEA through the closed system that you've heard about before of distribution to prevent diversion, and also to assure that these products do not fall in the hands of abusers. The DEA also administers drug allotment and accountability systems to ensure against loss and diversion of controlled substances. While some have questioned whether the quota system needs to be reevaluated, we do not believe that doing so is an appropriate way to address concerns with prescription drug abuse. Further restrictions of the quota system could actually hinder access to important medical therapies for the patients who rely on them. For example, there are drugs specifically designed for attention deficit disorder and attention deficit hyperactive disorder in the quota system that are currently on the FDA's drug shortage list. Thus, we are concerned that if Congress starts to tip the balance in the quota system, it could actually have unintended consequences on the patients who need these medications. GPHA has also been participating in the Pharmaceutical Distribution Security Alliance, or the PDSA, to develop a consensus technology model for increasing the security of the drug supply chain in the United States. As part of this model, manufacturers have committed to maintaining a database that would associate unit-level data and lot number association. GPHA believes this model will deliver greater safety to the patients and help to achieve FDA's stated goals of enhancing the identification of suspect products. But no matter how secure we make the supply chain for prescription drugs, ensuring safe use of these drugs is a responsibility that rests on all of us. In fact, recent studies suggest that the problem with prescription drug abuse in the United States today primarily stems not from drugs that are outside the legitimate supply chain or have been obtained illegally through the black market, but instead from those who legally prescribe and are available in the homes. According to a 2010 National Survey of Health, more than 70% of people abusing prescription drugs are doing so with products that were obtained either from friends or relatives. The generic drug industry has been a leader in addressing the problem on drug diversion. We believe that education is a key component to addressing this issue, and as such, support efforts such as the American Medicine Chest Challenge, Smart RX, and the National Council on Prescription Information and Education. In addition, our industry has focused its efforts in the area by joining the brand industry, patient groups, and the FDA to develop the REMS program, which addresses long-acting and extended-release opioid medications. REMS, which is short for Risk Evaluation and Mitigation Strategies, are special programs that are used by the FDA to help prevent adverse outcomes for the patients. And through the education of key participants about the risk associated with the medications and the proper and legitimate use of these medications. Madam Chairman, thank you for the tireless efforts to combat the problems of the prescription drug abuse in this country. You know more than anyone that this is very much a multifaceted issue that will require multi-stakeholders solution. Thank you, and I'll be happy to answer any questions.
Thank you, Mr. Goff, and I recognize myself for 5 minutes for questioning. And I just wanted to say I get very frustrated anytime I hear denial from anybody in front of this committee, as if they don't have a role in this. I think that there's plenty of blame to go around. There's no doubt, and in the private sector, if anybody was analyzing statistics and looking at the number of overdose deaths screaming upward, I mean, Donald Trump would say you're fired These statistics are staggering. The attorneys general pointed that out. They did a fantastic job. But something that really struck me, and it's to the pharmacy, the two pharmacy representatives, the murderers of the 4 people in New York. Now, the bad guy, the assailant, whatever you want to call him, was an addict too, correct? And it seems that are these robberies, are these crimes on the uptick because of the prescription drug epidemic? Are they addicts themselves, and are they actually, which is worse? Are they, I've seen people trying to go through withdrawal. They'll do anything to get the drug, anything at all. So are you seeing it because they're addicts, or just people who are trying to divert it to the black market?
I can't speak with a great deal of authority here. I think it is a combination. To the best of my knowledge, I have never seen a patient come in that I could say this person is in withdrawal. I think that there is so much money involved with the black market of this. I think there are so many people that enjoy the euphoria. There's a demand, and somebody is going to meet that demand. Some of them are evil enough they will do whatever it takes to get it.
But it's not the euphoria. They need a basic level to sustain themselves. So let's make it clear that it's not to sustain a euphoria. At any point in time, it becomes so that they can live, correct?
Yes, ma'am. But what I mean by euphoria, it has been proven over and over that people in true organic pain do not get euphoria from the pain-relieving drugs. If they are an addict, they do. The threshold to keep down the withdrawal syndromes does keep rising. They do have to have more and more, probably more often and more often.
Right, Mr.
But I don't know if the people committing the crimes are addicts or salespeople.
Mr. Nicholson, do you want to weigh in on that?
Thank you, Madam Chairwoman. First, I would add that I start off by saying that nothing is more important to our members than the safety of their patients and their employees. And I would also add that the incidents that you're talking about with respect to deaths from pharmacy robberies, the pharmacy robbery problem is in fact not, well, from what we're hearing, is not a nationwide spike, but it is spiking in certain geographic areas, such as in the greater, in the Northeast and in the New York metropolitan area. To help address these issues, we work on a number of initiatives. We have been recently meeting with the officials at the HIDA office in that area to develop solutions that would help pharmacies to prevent these types of circumstances in the future.
Do you all flag and identify willingly, if an addict is willing to disclose to you he's addicted to opiates, and I just want you to know in my record that if I come asking for these, I know it presents a whole host of other problems, but there are these sorts of things that pharmacies are not addressing right now currently, correct? Are you able to say, I know you can say you have an allergy to iodine, and you can put that on a patient's record, correct? But can you say no an addiction to a substance with a patient's willingness to provide that kind of information? Do you track that data?
Well, the information that goes into a patient profile is provided either by the patient themselves.
So I'm asking you, do you specifically, if a patient says to you, I'm in recovery for an opiate addiction, if I come to you with a prescription for Opana, whatever, or
right.
Vicodin, whatever opiates, please talk to me, counsel me first. Call my doctor and say, Doc, I want you to know. Do you do that now? I mean, that's a basic, simple step.
The basic, I think, the code of practice would be in the situation where a patient comes to you and says they're an addict, the ultimate goal would be to refer them to a treatment.
Do you keep it on their record? It's a yes or no question.
I can't answer.
Yeah, because the answer is no. But let me just move on because my time is limited. I just want to go down the line, if I might, and get a yes or no answer out of each of you. Do you agree with me that is there an epidemic on prescription drug abuse?
Yes.
Absolutely, yes.
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 Do you agree each of you have a responsibility in finding a solution to this problem?
Yes.
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 Thank you. Lastly, I'm just going to close with this one thought, that I am a little bit frustrated by the notion that a prescription drug monitoring program is punitive. It shouldn't be. My daughter was a professor of, my father was a professor of medicine, and I really hold in very high regard doctors and understand their limited time. Same with pharmacists. But when we're thinking this is a punitive measure rather than a holistic approach, the ability for each of you to see a patient in their entirety, perhaps if we change the language, it's not punitive, but it's supposed to be an added tool that will actually help you provide better health care to your patients, your consumers, your customers. I think that that would help if we could change the feeling and the language, and I'm happy to work with all of you on that. And my time has expired. I'm happy to yield to Mr. Butterfield for 5 minutes.
Thank you. I'm happy that the chairman went a little bit over time because that kept me from having to ask each of you the question about whether or not you feel some shared responsibility in curbing the abuse of drugs, and each one of you answered the question as I thought you would. I don't get the sense for 1 minute that any of you are not sensitive to what we're talking about today, and so I thank you for coming. I thank you for what you do in your industry, and just encourage you to let's work together to try to solve this huge problem that we're facing. I asked this question of the first panel, and I'm going to try it again, and then I will close it out and head to the airport. Law enforcement efforts in one state may certainly yield reductions in the number of pills dispensed or hospitalizations or deaths. All of this is commendable if it happens within the state's border. But how can we be sure that addicted individuals simply don't go to another state and continue to commit the crime? We've asked other panels about that, and it's the elephant in the room. I mean, that is the big problem. If we fix the problem in one state, it's very simple for the addict to go to a neighboring state. Help us with some of your ideas on that very quickly, Mr. Gray.
Please make sure your microphone is on.
This down right. Here we go. All they have to do is get in a car and go, and I think ultimately the solution is going to be the ability to link up these PDMP systems and what other health IT record systems can be done across the country, and where doctors in Florida or doctors in Michigan can look at, can go online and see what each individual patient is doing. I mean, that's the only way to kind of link up the information flow. So a pharmacist in Tennessee can look up and understand that this patient was also just recently at a pharmacy in Florida, and now they're up here. But right now, as you heard the earlier panel, these systems are discrete by their states. They're not connected, so the information flow isn't there.
Thank you. Right.
Is it on?
Yes.
I don't know why they can't be connected. There are nationwide systems right now that we deal with every day with insurance that will feed back to us in a matter of seconds. There's a drug allergy on record to this. They've had it refilled too soon. It's not on our formulary. There's all sorts of information that comes back in seconds. I don't know why something like this, but I'm the most technologically illiterate person in this room. But I don't know why it can't be done.
I would agree with Mr. Gray and Mr. Harmison that yes, I mean we definitely need the major solution is to connect the prescription drug monitoring programs. And at NACDS we support appropriations for NASPR and for the Harold Rogers prescription drug monitoring program to provide funding to the states so that they can upgrade and better maintain their prescription drug monitoring programs and work on programs to interconnect them with each other. I also would add that we are hopeful that as the healthcare delivery system becomes more interoperable, that pharmacies and prescribers and hospitals and other entities will have better access to the patient's full record, so that there won't be gaps that would allow a patient to go from prescriber to prescriber or from state to state.
Counsel?
Similarly, prescription drug monitoring programs, we think that they can be an efficient and effective tool in helping to identify folks for treatment as well. And some of the solutions that have been talked about today include making sure that information is provided to these state prescription drug monitoring programs in real time, but also enhancing their interoperability across state lines so that you can utilize this data to its maximum effect.
All right, 50 seconds.
I would concur with my colleagues on the panel. The PDMP is a system that is in place, but it does not cross borders at this point in time. And as Mr. Harmison said, the reimbursements are instantaneously. Why can't this be instantaneously?
Very well. Thank you.
Thank you. Mr. McKinley, you're recognized for 5 minutes.
Thank you. Mr. Gray, I think you started in a direction, and I want to follow back up again. Maybe, but then you stopped short of going that direction. Question: when we've spoken with the DEA, they claim for the distribution groups, they give you very specific suggestions for improvements or otherwise how to. Right. I have a feeling that there's a breakdown from what they say they're doing and what you in the distribution business are the distributors getting good advice, good direction when they go to the DEA and ask for improvements to their delivery system before they pull their registration?
That's the big debate, and if you talk to my members, they would tell you that those meetings, particularly at the regional level, tend to be deficient in solid advice at the end of the day as to whether or not a particular pharmacy should have a stop order as far as delivery. Our members started in this process with the DEA 4 years ago, as they said. This is a relatively new program. It was certainly a novel idea to consider the distributors a choke point. I think that's kind of a pejorative term for what we are trying to do as a team. As Attorney General Bondi said, we should be working in cooperation and collaboration with the DEA, and we shouldn't be in an adversarial posture, which these things, when you issue an ISO, that's what you end up, as was stated earlier. So what happens and I've talked to most of my members about this, and a common situation that will occur is that there will be a discussion. The distributor will sit down and say, we have reason to believe we see some spikes, something's wrong with the ordering of this particular pharmacy. We think maybe they should be cut off. What do you think? And the common refrain, I've heard this more than once, so there's got to be some element of truth to it. The common refrain is, that is a business decision for the distributor to make. Well, sure it is, but then that business decision can be used against you if you decide not to. And the questions that we submitted to the DEA last June 1st to Administrator Lenhart attempted to answer some of those specific questions within the confines of these meetings. A question a distributor would obviously have about a pharmacy practice. And this all stems to the data discussion earlier. They have data we cannot see. We cannot see that a pharmacy may be receiving deliveries from more than one wholesaler. All we see is our numbers. And that has been a source of frustration. I'm hoping today we can turn the dialogue into a constructive one. It's not us versus them, but how can we work together? I think we can make a lot of progress working together.
Let me stay on that question. If there are two other issues with it. First, are the pharmaceuticals, the distributors, are they compensated for doing this police work for the DEA?
Oh, no. This is all out of the distributor's pocketbook. Our companies have invested tens of millions of dollars in doing this.
Thank you. So a smaller distribution firm, how do they do that?
Very expensive. If you want to talk to some of them, I can make that happen.
I just wonder, is the long and the short of this with the DEA trying to put the smaller distributors out of business?
I wouldn't want to speculate on that. I can't imagine that would be the case. I think the DEA is absolutely fervent and correctly so in attempting to stop this problem. But I think, like any new initiative, we're in our dating period and trying to figure out how to get along.
Is this one of those unfunded mandates that we're passing on to the companies to do, and we're not going to compensate them? Then we're going to turn around and criticize them for the cost of pharmaceuticals?
Well, that's an interesting way to put it. But as I say, the hardcore facts is when we put in these monitoring systems, it is at the company's expense to do so.
I want to see this in a most robust way to try to correct the problem. But I have this nagging feeling here that their parts of the chain are not being treated equally, and I hope that the DEA will revisit how they work with each.
Well, we do too, because we have a long history since I've been on board in 2004. We have worked we were the first responders in Katrina. Our companies were the ones that got in there and we were the only ones that got in and got medicines to the people stranded in New Orleans. We were the ones that set up the vaccine tracking system with the CDC in a cooperative effort. We worked cooperatively with the Secretary of HHS to develop the system for bird flu maintenance and stockpiling around the country. We have a long track record in the last 5 years of working hugely cooperatively with federal agencies and the government. I would love to see that same level of participation cooperation with the DEA, because I believe they are correct. Together, we can solve a lot of this problem. If they help us help them, we can make a lot of strides to solving this problem. But we're working in a vacuum.
Thank you very much. And I'd like to begin wrapping things up. I want to thank all of our panelists very much for being here today, for your time and for your commitment to this critically important issue. If 30,000 Americans died every year from food poisoning, Congress would take action. If 30,000 Americans died from pesticide exposure, Congress would take action. For that matter, if 30,000 dolphins died and washed up on our beaches every year, Congress would take action. So why are the victims of prescription drug abuse treated any differently? But working together, as we've all said, I know that we can come up with some good answers and we can save lives. So I, again, thank you all very much for being here, and especially for weathering the delay that we had this morning. I would like to remind members that they have 10 business days to submit questions for the record. I know we will have one specifically about on-dose marking. And so we will submit questions to you, and I would ask the witnesses to please respond promptly to any questions you might receive. Again, thank you, and the hearing is now adjourned.